A very warm welcome to Godrej Memorial Hospital on behalf of ISCP and Thane Surgical Society. Dr. Mrunal Ketkar has come all the way from Pune, and she'll be speaking on office procedures for hemorrhoids. Yes, sir.
In fact, we require no introduction to her, but still I'll introduce, because she is such a lady, you know, she has reformed in medical education, and she is in charge of medical education system now. And in fact, I would like to be her student for this faculty. Thank you very much.
Next time इनको mic नहीं देना.
He's a very good singer. That's an additional qualification. Sorry. Additional. Very good singer.
Now we'll not take
That yes, no, that you will hear it. No, if you log in, there is All India national level forum. 8th March at 8 p.m. So you will hear me on 8th March 8 p.m. Yes, ठीक. Thank you very much, sir. Thank you to ISCP, personally to Dr. Chivte sir and Dr. Ladukar sir for giving me the opportunity of presenting on this forum again after such a long time, sir. Yes, we are meeting after a long time, sir. Yes, 3 years. We were busy managing the COVID, but still, as sir has told you, I am a teacher at heart. Somebody, he said that it's nice to listen from a teacher, because then we don't have to take notes. All ready-made notes are available to us. So that is how this is, sir. So basically, I'm going to restrict myself on to OPD procedures for hemorrhoids. Most of us are doing many of these. Since the topic is OPD procedures, so without starting the lecture, I would like to just ask a few questions that what is the most important instrument in any proctology from surgeon's point of view? Yes. So I know that all of you are here with me. So an intelligent finger is the most important instrument that we have as surgeons. And I think doing a digital rectal examination with an intelligent finger itself is the first most important procedure. Though I have not given it a place in this, but I thought, okay, since the heading does not cover, let me talk extempore on this. So a intelligent finger which is capable, so whatever is there in your mind, you will be looking for it. So it gives me immense pleasure when I teach my students that you can actually feel a hypertrophied papilla. You can actually feel a dip because of the internal opening of the fistula, and which is usually right next to that papilla. So as a teacher, whenever you see the theory that you have learnt in a subject getting reflected in actual practice, that gives us immense pleasure. For a surgeon on an OT table to revisit the anatomy gives the biggest pleasure. Okay, it's not 10 times, even if you tell them 10 times in your theoretical lecture that how important anatomy is, but when you show them on table, the students do realize, and then they want to revisit the anatomy. Okay, so that much distraction is over. So let's move on to OPD procedures for hemorrhoids. So as we know, the hemorrhoids, all of us are aware of this particular classification. In addition to this, we can further divide, like you know, grade 1 is just bleeding, grade 2 prolapsing but going in on its own, grade 3 it remains prolapsed and needs to be reposited, and grade 4 is prolapsed hemorrhoids and complicated hemorrhoids, as it was told in our Balian love. So in addition to this, there is A, B, C, D that is involved in this classification. A is, there is just less than half a circumference, because sometimes you cannot put the hemorrhoids into 3, 7, 11. You have those secondary hemorrhoids also. So if the secondary hemorrhoid is occupying less than 20 or just 25%, less than 50%, it is A. up to 50% B, more than 50 almost circumferential, and circumferential, that is A, B, C, D. So this gives a clinical touch to your examination finding. You can write say grade 2A or grade 2B, which includes even the secondary hemorrhoids. Okay, are you with me for this? Okay, fine. Again, the second classification, which is most important for us to understand the OPD procedure, is the internal and the external hemorrhoid. Majority of the times when you're doing office procedures, you are tackling the internal hemorrhoids. Rather, I am going to talk about office procedures for internal hemorrhoids rather than the external hemorrhoids. Obviously, because external hemorrhoids come from below dentate line, which is a sensate zone. So just the differentiation, the most important point amongst all this. So external hemorrhoid is below the dentate line. It is basically, again, varicosity of veins bone on either side, but this is from the inferior rectal artery, whereas the internal hemorrhoid is from the superior rectal artery. And the external hemorrhoids are lined by modified squamous epithelium, and there it is painful, whereas the internal hemorrhoid is pain insensitive, and they usually prolapse out. Not so commonly they thrombose. External hemorrhoids are more commonly, they will thrombose and become much more painful. So this is actually given in our colorectal society, the protocol which is there. Okay, so this is, sir, I can share the whole presentation with you. I have a printout also. So whenever, whoever wants, you can just pick up so you can just listen to me. So this is complete. So I will be restricting myself to, the pointer hai? Yes. I will be restricting myself to grade 1 and grade 2, for which the OPD procedures are usually followed. So we will see each of the OPD procedures one by one. So this chart is really very good. It gives you a very good overview of all grades of hemorrhoids and the preferred and evidence-based management of the hemorrhoids grade wise. So basically, again, this is not an OPD procedure, but this is from where you should start talking to the patients. It's the dietary and the lifestyle modification. I really like those two lines there. You don't defecate in the library, so you shouldn't read in the bathroom. I still remember, I have the vision of my father taking the newspaper to the bathroom. Okay, I don't think in the newer generation, but the newspaper has been replaced by mobile. Yeah, so I think that is what is the rule. We need to talk to our patients. We need to ask, go into details when they come with hemorrhoids. The young brigade, they come with hemorrhoids, many of them. Just last week I had a 18-year-old girl who was brought. She was working as a secretary in one of the vascular surgeons OPD, and she was brought by her mother with acute fissure and bleeding. So this is nothing but there is a change in lifestyle needed. That girl was, okay, she was going to college, and evening time she was working, but there was no exercise whatsoever, and always on binge eating of all wafers, biscuits. So I think we should always concentrate on dietary habits and lifestyle in our proctology practice, because a lot of things will get solved if we really address to these two issues. Next is, yes, the flavonoids. Which ones are you using in your practice? Yes? Yeah. So deflazacort, because that contains, I think, hydrocort also. Many of the, so basically this purified dobecilate, yes, both, it contains both. These are flavonoid fraction, micronized flavonoid fractions, dazoflav. Okay, that is one of the common name that is there. Daflon, Dazoflav, आणि तिसरं I think Venusmin मध्ये पण yeah. So all these three contain the same amount, and it really helps because these are all nothing but vasotonic drugs. Vasotonic drugs. So they improve the tone of the vessel. म्हणजे vessel which has become loose. We know that there is a varicosity, isn't it, involved? Part of varicosity, the vein wall has become loose. So these are vasotonic drugs. Definitely they will help in grade 1. Sometimes when you cannot take the patient on table, yes, they will use, you can use them as a tide over also. Okay. Another drug, I don't know, I used to use it for fissures or grade 1 hemorrhoid is from Himalaya. नहीं पाइलेक्स पण नहीं है, दूसरा है थंबा स्टिप्लॉन. That is for bleeding, stopping the bleeding, Stiplon. And I have seen good results with Stiplon. Now it doesn't form part of this, but it does stop bleeding. I have not gone into details of the Stiplon, but it does reduce the bleeding 100%. Okay. So basically again, let's go back to, so it must be having some vasotonic effect, Stiplon also. The contents they are not able to tell us. So oral vasotonic drugs, they increase the vascular tone, they increase the lymphatic drainage. So this is long-term hemorrhoids, they will help. Anti-inflammatory effect is also there. And definitely they have been shown to be effective. And as Ladukar sir said correctly, you have topical application containing calcium dobicelate and docusate sodium. So how does calcium dobicelate act? It decreases the capillary permeability, it reduces the platelet aggregation, stops bleeding, that's how the dobicelate will work, reduces thrombus formation. Okay, so when you are treating for the first 48 hours the patient with thrombosed hemorrhoids, this is the drug that you can use for all these actions. And docusate sodium, which acts as a stimulant laxative. So along with the other, it will work. So this is as far as the oral medications are concerned for hemorrhoids. Let's move on to real OPD procedures. So what should be the aim of the real OPD procedures for hemorrhoids? What is the aim? What is the patient looking for from the OPD procedures? Okay. Bleeding, stoppage of bleeding, yes. So stoppage of bleeding. So you have to relieve the symptom for which the patient has come to you. So almost all of them. In fact, infrared coagulation has been used even in the bleeding hemorrhoids, actively bleeding hemorrhoids. Okay. Many a times the patients come with, okay, history of bleeding PR, but actively bleeding hemorrhoids, I have not, I don't have any experience of infrared, but the literature mentions yes. So Ladukar sir has the experience, and in the actively bleeding hemorrhoids we can use it. Okay, so this is one. So yes, what the patient wants is control of hemorrhage. What else? We are talking about office procedure. That means?
The patient is scared of being admitted. Patient is
yes.
scared of being used scalpel on his body.
Yes.
He's scared of the whole operation.
Operation, yes. So it has to be an office procedure, preferably not requiring any anesthesia, and patient can go home immediately or maybe in 1 or 2 hours. Okay, and preferably less recurrence. Okay, so one of the downside of these office procedure is many of them require multiple sittings. Okay, so this is what you can expect from office procedures. They are applicable to grade 1 and grade 2 hemorrhoid, and they might require multiple sittings, but they can be easily, comfortably done as office procedures. Okay, so that is what is the description of office procedure of hemorrhoids. So this is one important line. I'll give you a minute to read. So we have to be very, very careful. A rectal bleeding which is walking into your office, just attributing it to a local cause, then you are losing actually a chance of diagnosing something which is very sinister. So never ever do that. So in which conditions you should look for colonoscopy or some other endoscopy, these are the indications. Okay, so just don't jump ki this is hemorrhoid. It could be a secondary hemorrhoid, secondary to a malignancy. Okay, so what are the indications? Generally, this should be the guideline for planning a colonoscopy. And you should be able to convince the patient ki why I am not immediately doing your office procedure, why you require advance. Okay, agreed, all of you? Fine, right. So this is very, very important. Every bleeding PR that walks into your OPD, we must give this thought process. We must ask for some sort of, especially elderly person coming with bleeding PR. Sigmoidoscopy. So what is a office procedure which is, if we are not trained in colonoscopy, sigmoidoscopy. I have done 6 months under Dr. Chulani and Dr. Shah sir, who is no more with us. So there was a colorectal unit when I was doing a residency in JJ way back, And I have done 6 months under, I have been trained under Dr. Chulani and Dr. Shah. And the dictum was every patient before being posted for surgery, we always did. So there were 2 visits prior to surgery. First visit, local examination and whatever required. Second visit, every patient used to undergo sigmoidoscopy, rigid sigmoidoscopy in OPD. That was a dictum, and I think all of us, and that's not a very difficult sigmoidoscopy. So that is, I think we should add sigmoidoscopy in our armamentarium of OPD procedures. But Dr. Anjali is going to talk in detail of sigmoidoscopy, so I'm not talking more about sigmoidoscopy. So let's proceed to the first office procedure, and this, I think all of us should have it in our OPD and can be easily, very easily done, which is called as hemorrhoidal band ligation, which was described by Barron in 1963, usually done for grade 1, grade 2 and selective grade 3 who refuse to come on table. Okay, or for some reason you cannot get them on table. Another special, this is a patient who has bleeding tendency or hemorrhoids. Actually it's not hemorrhoid, related, say patient has a portal hypertension also. He's bleeding down. So yes, you are going to start the medical management of portal hypertension, because you know that this is not hemorrhoid, but then actively bleeding, sometime you can try band ligation. Okay. So it's an alternative therapeutic modality in patient with higher risk of bleeding. Okay, especially in this era, post-COVID era, maybe I think the importance of band ligation has increased even more, because you're scared to touch the patient who has come with bleeding, because he might bleed more or he might get thrombosed. Okay, so
the occurrence of hemorrhoids or bleeding PR has been increased in post-COVID.
Maybe it has
because
increased,
of,
okay.
Yeah,
oh.
Maybe because of the drugs used, maybe because of vaccine side effect, whatever. We are getting more number of patients compared to pre-COVID era.
Yeah, but what is a local examination from where the hemorrhoids get bleeding? Okay, fine.
Right.
So initially they were not bleeding, but now the bleeding tendency due to some reason has increased.
In the post-COVID era, patients are so much health conscious.
Yeah.
The smaller bleeding,
Yes.
they push them to the doctor. And we are fortunate to diagnose them at grade 1, grade 2.
I think so, more opportunity for this.
Yes, yes.
Okay. Thank you, sir. Thank you for sharing that, sir. Okay. So the success rates are higher and the evidence, level of evidence is excellent. That is grade A and evidence level 2. Okay. So basically, what is the mechanism? What is piles? It is the anal cushions which are loose and they are coming out. So what you want first is they should stop bleeding, because that is a complaint, and secondly they should remain inside. That means there should be a fibrosis. So that is the aim, and that is what is happening here. So you are applying a band at least 2 centimeter above the dentate line, which is an insensate zone. So there is ischemia because of the band, necrosis, and further it gets converted into fibrosis. So we are achieving the second intention, that is, it is getting fixed higher up. So it will not prolapse. So the patient's 2 complaints, that is bleeding, and secondly something coming out per rectum, both complaints are taken up. Okay, and this is well tolerated. Absolutely, it's just like doing any other proctoscopic examination. The patient is not going to feel more than that. So this is definitely a doable, and we used to do this day in and day out in that colorectal unit, banding procedures. So this is how. So there are 2 types of, so either you hold the pile mass with the forceps, or not forceps available even with the our Ellis forceps, but it requires angulation. That's why a routine Ellis cannot be used. But you can have a suction also. There is a modification, so that was available with us. So there is a small suction cannula which you put through that. So you are supposed to, whatever you are going to hold, put an instrument through this round. The band is applied over here. So you pass your forceps through this, hold the pile mass, pull it in. See this here. So this is a suction cup which is applied. It pulls the pile mass inside, and then band is slipped over it. So this is very easy, very simple. You do not require any assistance or anything, only for, especially with sir's self-illuminated proctoscope, you don't require even assistance. Okay, initially, old days when the proctoscope were not illuminated, you require an assistant at least to show you the pile mass. Here, even that is not required. So that is a procedure. the contraindications. So patients using anticoagulants actively. So just like any other procedure, you can stop the anticoagulants, and there are different rules for different anticoagulant. Antiplatelet ke liye there are different rules for aspirin. Nowadays they say there is no need to even stop the aspirin also. Okay, so depending on that, if possible, you should do it. Then patients with acutely thrombosed hemorrhoid. Okay, you cannot pull them, they are already painful, so this cannot be done. Patient with large grade 4 hemorrhoids which are remaining outside, this is not the correct procedure for grade 4. Patient with septic process, yes, we know that in the septic process, if you do this intervention, it is going to cause pylophlebitis and it can give rise to major issues. Then rectal malignancy, significant rectal prolapse, patients with chronic fissure, because the patient is already in pain, and if too insufficient, it's just the beginning of grade 1 and you are not able to pull it only through that drum, in that case you won't be able to do. So too small or too big. Sir, so you want to say something, please.
One of the important contraindication is one should identify the type of hemorrhoid first. Many of the people I have seen that they are applying it for external hemorrhoid.
Oh, no.
And then the problem starts. Those who are quacks,
Yes.
those who are quacks, they apply it on that external hemorrhoid, and then the patient lands in so much of trouble. So he should be able to understand what is internal pain and what is external pain. That is the important contraindication.
Sir, that is why the teacher giving lecture. That is why the first, second slide were differentiate between internal and external hemorrhoid, and these office procedures are only for internal hemorrhoids. Okay, you're with me. Thank you, sir. Thank you. So, I mean, see, the point gets reinstated. Again and again you say it out and it just stays here. Okay, so complications, pain, if you have not correctly applied it. If you are above dentate line, 2 centimeter above dentate line where the pile mass starts, it's definitely not going to cause any pain. If there is pain, patient complains of pain, one is you should think that, okay, my procedure has gone wrong, or I have missed some inflammation. And that's a bad this. Okay, you cannot remove that band. But yes, you can give painkiller, maybe you should start antibiotics. If you are suspecting that, okay, my band has been applied in the right place, but still the patient has pain, that means there is some inflammation there, antibiotic is mandatory. Vasovagal symptoms, if you have not explained the procedure properly to the patient, or as I said, if there is a fissure and the patient feels pain, okay, but yes, all of us can tackle any vasovagal attack. We are most well equipped for that. Bleeding 1 to 5%, that is expected, but it's never much. External hemorrhoidal thrombosis, which is intero-external, it can occur, but it's not very common. I have never seen actually in so many patients that we did during that time. Even as a resident, we have not seen. Ulceration eventually is going to happen later on, but not very bothersome. We are just enumerating all the complications. Delayed hemorrhage, especially if you have missed or if you have fired the band in an infected hemorrhoidal mass. And localized infection or abscess. And sepsis. So let's move on to, yes sir.
3 line of comments on band ligation.
Yeah.
Number 1, one should use a good quality of bands because when you load the band through the loader, which is a conical one, if the quality is not good, that will either break while loading or it will break after some time after applying. This is the first line. Second line of caution, never use glycerin or Lignox jelly for loading this rubber band.
Yes.
What people do usually, they put some oil, silicone oil, Lignox jelly to load the band on with the conical applicator.
Then slips.
And when you apply it on the hemorrhoid, after some time or on the table, it itself slips out because of that lubrication.
Yes.
Third word of caution, do not use previously or long standing loaded band because after a certain period of time it tends to lose the elasticity. So every time you use the freshly loaded band so that its elasticity at its younger age.
Yes,
Thank you.
thank you so
Thank you
much
so
for
much.
adding these. I think I will add that and
the
maybe
slide.
the actual loaded bands also and the images of the
We
bands.
should freshly
Okay.
load
Silas.
and load
Yes.
it very slowly, not in a haste.
And two, we used to load at a given time too.
Yeah.
Yeah.
We had to load.
Yeah, load two, because one of them, you're already doing all that whole procedure, and suddenly if the first one fails, again you remove, again load. So load two at a time, and then. So I think the fourth point to
That
be
fourth
added. in
point
that.
should be
Yeah.
included in the slide.
Yeah, okay. Silas, black one. Hmm. Hmm. Okay.
Sir, in fact,
Silicon, yes.
हाँ, yes, some कुछ लोग बोलते हैं imported है, मैं अब वो imported नाम पे लिया है, but वाकई अच्छा कर रहा है. Black one is ready.
Black
Yes,
one,
sir.
black
Yes.
one imported बोलते हैं बराबर है
Yes,
sir.
yes, yes.
So it is, I think, 200 rupees for 50, ऐसा कुछ है? 10, 200 rupees 10. Yeah. Which? No. Because you don't know. I think during our residency we have tried all those. Yes. Yeah, but then you have to. Foley's catheter? Cut. Oh my God! Look at that. Indian jugaad. Okay. Indian jugaad, absolutely. Yeah. So let's move on to the next one. So that is sclerotherapy. So we've finished hemorrhoidal band ligation. The second one is sclerotherapy. And this syringe, I think many of us are from the old brigade. So we remember the Gabriel syringe, the image which is there in Bailey and Love. The new Bailey and Love doesn't have all these things. Okay, they really miss out on so many old things that we had in our Bailey Love up to, I think, 20th edition. Okay, so it was described by 1869 by John Morgan. So this was described even before band ligation. Okay, and again it is for grade 1 and grade 2, and this can be used almost for all types of hemorrhoids, even the smaller ones. Those who cannot get pulled in the band ligation, they might be possible. You can do sclerotherapy of those. Okay, so here you go at least 1 centimeter proximal, because you are just giving injection with a 25 number needle. So you go, but still you go 1 centimeter minimum proximal to the dentate line for the injection. And the sclerosants, I think all of us are aware. So sodium mauryate, 1% tetrahedral sulfate, or polydocanol, or the old one that is described in books is phenol in almond oil, but not in almond oil nowadays, in vegetable oil. So these are all. So you can give 0.5 to 1 to 3 in single hemorrhoidal mass. So that is sclerotherapy. So again, how does it work? Basically, it works by causing an inflammatory action. It causes first inflammation, thrombosis, followed by submucosal fibrosis. So your injection is going to be in the submucosa. Just penetrate the mucosa and inject in the submucosa, causing the submucous fibrosis, and and hence the pile mass will be fixed wherever it is there, and after over a period of time it will slowly shrink because of the thrombosis and fibrosis. So this is definitely a quicker procedure as compared to the band ligation. It is painless, again absolutely painless, and you can call the patient for follow-up after 3 weeks, 6 weeks, as your protocol may be, but 6 weeks follow-up once to confirm the shrinking is should be done. And again, multiple sittings can be required for this. At a given time, I think I have not injected more than 3 at a given time, so that is adequate. So you can have multiple, and then as I said, you can inject in the smaller pile mass, which is not possible for banding. So complications, again similar type of complication, mucosal ulceration, necrosis, rarely septic complications. If you have not, it is a potential area for sepsis, and you are injecting in that area. So if you have a good preparation, an empty rectum and anal canal, and clean rectum anal canal, you should be able to avoid this complications, septic complications. Otherwise it's not, I mean, you should not get scared ki, okay, if I'm injecting. No, sepsis is not that commonly seen unless you have really, it's an immunocompromised patient and an infected zone. Efficacy, it is best suited for grade 1 and recurrence rate is 15. Band ligation recurrence rate is around 11% and this is around 15%. So you require, so you give a second injection. Okay, so the recurrence rate will definitely come down. Let's move on to the third one, that is infrared coagulation. So Ladukar sir can share some of his in this. So basically it was described in 1979, recently described. So high intensity infrared radiation. So basically it's a light which gets converted into heat. That is what is the basis. So you have a localized high dose of heat and this is going to give rise to coagulation. And as I had said before, in an actively bleeding hemorrhoid patient, it is very good. So how many sittings can you get? So basically the light penetrates the tissue, it gets converted into heat and it coagulates. Causes basically protein coagulation which extends for a zone of around 3 millimeter all around. It is 1 to 1.5 single pulses of 1 to 1.5 second and you give such 4 pulses maximum per pile mass. Okay, and this is ideal for non-prolapsing hemorrhoids. Okay, because otherwise it will interfere. You will not be able to do the proper infrared coagulation. So it should not be a huge pile mass, say grade 3, grade 4. Basically, so ideal I think is for grade 2 hemorrhoids and multiple sittings again are required. So that is how those marks will be seen. Ladukar sir, you want to say something?
Actually, we were all compatible with Barron's band ligating gun and that's the procedure.
Okay.
Then why did it come? Actually, there are so many flaws also in band ligation. Sometimes if you are not well experienced, I have seen some of my colleagues applying band ligation and patient is bleeding after band ligation. That's I have also seen. So it is somewhat tricky. You should have that idea. So in infrared coagulation, it is, though it is a costly machine of 4.5 lakhs rupees, but I'm not routinely I'm not using it now. But earlier I used to use it. But sometimes for any of the reason, any of the incidents, I have to use it. Now I will tell an example. One person, a person of 24 years age, he came to me. He had a marriage a day after. He came to me. Sir, इतना bleeding हो रहा है अभी कि I cannot do anything.
Okay.
Now bleeding कहाँ से हो रहा? So and I put do PR examination. Nothing was palpable. Nothing was palpable. And then I put my proctoscope slowly. I said that there was a pretty big splatter. So how to arrest it now? And patient was bleeding very profusely. Patient had any history of mass. Patient was having actually portal hypertension. And that it was bleeding, and it was early portal hypertension, but there was, because of some hard stool he passed a day earlier, it eroded the mucosa and the bleeding started. So now tell me, at this juncture, patient is having tomorrow, he is having a marriage, what procedure will you do it now? There is no band ligation to be applied over.
Because there is not enough mass
no enough
to
mass.
pull it.
Now how to do it? Otherwise you have to take a figure of, to have a stitch inside. So this, at this juncture, this IRC helps quite a lot. IRC can, you just go beyond that point, actually 2 to 3 mm, you go above the splitter, you apply that IRC, and all of a sudden, in a very short span of time, it brings about the coagulation at certain point, it stops. This is one point. So this can be very well used in
active bleeding.
This active bleeding. Secondly, in fissure, I have seen some of the fissures having, even after doing internal sphincterotomy, they bleed. Now at fissure line, you cannot apply anything. So at fissure, when there is ulcer, you just apply it because it is submucosal coagulation.
But this will require anesthesia because you are applying at
yes.
fissure. This will require anesthesia.
This will require anesthesia or locally you have to do it, local application. So even if in doing fissure, when the patient is, you have done this fissure or internal sphincterotomy, but patient is bleeding, that time also it is very helpful. In grade 1 and grade 2, we managed, IRC is the best. There is no point. We discuss all those things, But in IRC, in grade and grade 2, the results are very nice, but you know that you cannot prevent recurrences. It has to be repeated 2, 3, 4 times. Then when the patient dies at 3 and 4, you have to do the surgery.
Yeah.
That's
So
what-
multiple sittings required. Yes, sir.
Yes.
Sir.
Fine mask need some supportive measures, and never apply laser if it is actively bleeding, and never apply the IRC at the point of bleeding also. That will increase the ulceration.
Okay. So this is how it has a side viewing scope which is transparent, and then okay, this is for the cryosurgery. Next, okay, so multiple sittings required. So that is infrared, finishes infrared. Just to complete the next 2 or 3 procedures third one is cryosurgery. So we finished band ligation, fourth one is cryosurgery. We finished band ligation, we spoke about sclerotherapy, then we first spoke about infrared, and then cryotherapy. Again another office procedure, as the name suggests, it requires specific instrumentation, it requires a specific scope also. Okay. So basically it is based on what is the mechanism of action is, it's based on cellular destruction by causing rapid freezing. So we are going at the other end. So here heat coagulation, and at the other end you have cryo. I think cryo is used more by our colleagues, gynecologists, for all the cervical erosion. So again it's an office procedure. Even cervical erosion, there is no anesthesia required. For small cervical erosion, they use cryo, and they use cryo much more commonly than us. So
Complication, madam, this is in cryo, after using it, it gives a large amount of mucus.
Yes.
So the patient goes on discharging the mucus. That is the
Yes.
complication.
That's what the
So it
third
is not
point.
accepted. I had earlier used this CO2. Like this nitrogen uses.
Yeah.
But that gives rise even.
It requires more time. You have to keep that cryo probe attached to that area for a longer
Side
time.
effect. Side effect is mucus discharge
Yes, so
continuously.
first 24
and that
hours-
is not tolerated.
It is, so you have to caution the patient that the patient is going to have profuse discharge per annum for next 3 to 4 days, and that is what you have to explain to the patient. No other procedure has this, but cryosurgery has this particular side effect, or say I would say discomfort to the patient definitely, and then they get scared. Okay, so profuse post-procedure drainage and delayed healing is one of the thing that you have to caution the patient against. It requires longer time. That contact time is longer. And yes, you do require local, because you are going to put that proctoscope for such a long time. So then it is preferable to do it under some anesthesia. Next, just to complete the next 2 things, one is BiCAP, that is bipolar diathermy. Okay, so again, if you want to use it without anesthesia, it needs to be really a smaller pile mass if you want to use it as a office procedure. So a disposable zircon BiCAP hemorrhoidal probe is used. Essentially, it produces a bipolar RF current. Okay, and the last one is ultroid, which is a monopolar current. So bipolar, there you have a bipolar cautery also, and you have a monopolar current which can be used. So we basically know the principle of bipolar and the monopolar cautery. Both these instruments are using the same principle, and then but they it's not mentioned in the books, but they will require some kind of local anesthesia. Okay, so and the second about ultroid is it requires much more time. So again, it is not followed, not picked up by many of the and a special non-conducive endoscope is required, especially because you're using a cautery in that region. So I have just finished all the office procedures enumerating, and I think we discussed the more doable ones here. So basically, do not forget importance of colonic evaluation. Do not forget or miss any such patient candidate whom you just operate his hemorrhoids and forget, and then later on after 6 months he comes with malignancy which is somewhere up. Okay, so we must not never miss out such a patient. That is my take home message first. Second is office procedures are easily doable. As sir has decided, he has his own experience. He prefers infrared to band ligation. One time investment he has done, and it is, yes, it becomes more impressive when you are taking care of a actively bleeding patient. Okay, so you choose which procedure is most easy and doable for you, and I think you should follow that. And not much separate setup. I mean, Barron's band, sclerotherapy, hardly investment is required. Infrared, yes, but then you depending upon your practice setup, you can choose one of the procedure and you can follow it. Thank you.
Madam, one. Yes. Very nicely elaborated by the madam. One question I want to ask, madam.
Yes.
In some of our OPDs, we receive the cases we have been treated by some unqualified persons. So they may apply some chemical, they may apply some hair or apply some silk thread, and in that case they slips and start bleeding. In that situation, how we should proceed? Because already somebody has done it, and the ultimately responsibility comes on.
Yes, sir. Sir, it is, I think, you are hinting almost at a secondary hemorrhage, which becomes difficult. The patient will come in shock. And such patients require one, hospitalization, thorough workup, higher antibiotic, and I would say examination under anesthesia first. So what are things which are possible? Okay, so I have seen an extreme. One is, if the tissues are not that friable, you are able to just inject, maybe you want to buy time, you can just inject adrenaline on top, okay, or sclerosant on top and get away. If the tissues are better, okay, or if tissues are better, you can also, first thing will be take a stitch as a surgeon, okay, and see. But the other extreme that I have faced as a lecturer in KEM, yes sir, in KEM माझी second emergency होती. Okay, I was sitting in our CMO room, and we had Todkar madam was my SR that time, and she just called me, madam, patient operated 10 days back, hemorrhoids, and alive with bleeding. The moment you know that it is more than 10 days, 12 days history, you are thinking only of secondary hemorrhage. And when I went inside the CMO's cabin, the patient was sweating profusely. He was sitting there talking. I said, "Pahila adava kara." Patient went into shock. The moment we give him spinal anesthesia, okay, Dr. Bhatia hote teva, anesthetist, आणि एवढ्या शिव्या खाल्ल्या, कारण I was the lone lecturer who had come from Mumbai. I didn't know Pune. तोडकरने blood arrange केलं नव्हतं. खूप शिव्या खाल्ल्या because I was the senior. Because the patient, the moment induction was given, you know that it's an hypotensive anesthesia, patient went into shock. Okay, so we have to be ready for such extreme and we literally put a Foley's catheter inside, inflated the balloon. These are non-urinary uses of Foley's catheter, and that worked. Okay, so the treatment can be just a figure of 8 stitch, sclerosant, adrenaline, buying time. आम्ही ते पण देऊन झालं होतं, पण ॲड्रिनालिन देण्यासारखी परिस्थिती नव्हती. द लास्ट रिसॉर्ट वॉज पुट इन अ Foley's कॅथेटर, इन्फ्लेटेड, पुल अप, अँड इट स्टॉप्ड. देन वी वेंट इन अगेन.
That was really a very, very nice presentation, madam. Thanks once again for taking out. Yeah. That was really a professor's speech. And thanks once again for coming to Mumbai from Pune and taking out the time.
I thank everybody for interacting.
Yes.
Because this is never a monologue. It's always.
How the students were?
Very nice.
Hello.
Guys,
सगळे असे स्टुडंट
नाही sir, it is always interaction, not interaction.
नाही असे स्टुडंट्स भेटले तर चांगलंच वाटतं.
मस्त सर, आणि तुम्ही, they were such value addition, sir. आता I am going to make that change in my presentation. Yes, I should put some commercial, जसं सरांनी सांगितलं, white आणि black. Okay, so I think I will put those commercial additions also. That will help. Company name. No, that's why, see, I didn't put those names. I just wrote them here and I said, okay, let me just take the names.
Anjali is coming. Anjali is coming.
Old
I'll
habit
ask Dr.
die
Kodwani next. Hello. Yeah. This thing. Now may I request Dr. Kale to moderate the session, and along with Dr. Kale, may I request Dr. Godrej to come to the stage. Dr. Kale, please. Dr. Kale and Dr. Khade. Next lecture is by another stalwart, Dr. Kodwani. He'll be speaking on the innovations in SIDS bath. Dr. Kodwani is a treasurer of ISCP, and he has a very huge practice at his hometown, Tumsur.
Thank you, Jitendra. Thanks to administration and staff and whole team of Godrej Memorial Hospital. Thanks especially to Dr. Jiten Chaudhary for arranging such a nice hybrid conference. And good morning to all those who are present here physically as well as virtually, those from their OPDs, living rooms, bedrooms, and wherever. So friends, the topic given to me is SIDS bath methods and new innovations. Just touching briefly the basics. This brings to all of you greetings from the Rice City Team Kodwani Hospital. Now touching the basics, what is SIDS bath? A SIDS bath is a warm, shallow bath that cleanses the perineum, that is a space between the rectum and the vulva or scrotum. Now why SIDS bath is to be given? First, the hygiene is very poor in post-surgical cases, particularly in anorectal cases. And in post-surgical cases, the patient is scared to touch, to wash because of the pain fear. The pain in anal area that gives a sense of scareness. And a SIDS bath with the warm water and maybe with some addition of antiseptic liquid, it works in many ways, like cleaning up the local area with maintaining the hygiene with local antibiotic, local antiseptic, and antiseptic in the water that controls local infection, and warmness of the water that increases the local blood circulation and takes away the pee substance and thus alleviating the pain. Here I should say that some practitioners do not prefer addition of any Dettol, betadine or hydrogen peroxide, and some prefer only going with the warm water. So both the ways are good. It depends on the individual choice. Now what are the prevailing customary methods of SIDS bath which are available, and what is the innovation? I'll talk on that. In our UG and PG days, as the Mridal madam remembers, a suitable tub or bowl is taken in which the warm water is taken with some antibiotic like Dettol or Sterilium or betadine is to be put, and the patient is actually asked to sit in that tub or bowl, actually to dip the anal area for 5 to 10 minutes, and even after every motion also. This is the way the tub were used earlier. In today's era also, in some most of the people they do like this. This is one of the available kit for the SIDS bath. The warm water is put into that, and with the hand pressure of the balloon, like we inflate the BP cuff, the spurt of water that goes into the anal area, and it gives a spurt like wash to the anal area. This is the another bowl. This is to be put on the western type of commode, and the bag is to be filled with the warm water. The bag is hanged to a little height from the commode, and the water comes through the pipe and it washes the anal area. But once the water is over, the game is over. So these are the available methods, these are the available kits. Again, this is the old one I'm showing. Now limitations to this method, which are already there. This method actually requires a squatting position of a person, and that too for 5-10 minutes, which may be cumbersome in some post-operative cases, some arthritic patients, old age patients, obese patients, or any patients who has undergone for any lower limb surgery, fractures or spine surgery. So squatting is really difficult. And in pregnancy induced hemorrhoids also, the patient who is already pregnant, they are unable to make a position of squatting and again sitting on the bowel in a ground level. It's very difficult. So this is the first limitation. Another one is, like I said, any previous ortho surgery of hip or knee joint or lower limb will be difficult for these type of patients to have a seats bath. Also, improper communication may result in inefficient or futile seats bath. Like यदि आपका स्टाफ पेशेंट को बताता है गर्म पानी लेना है और उसमें बैठना है, if she doesn't tells clearly कि you have to dip the anal area, the patient sits above the water level and what he or she feels कि fumes will come and that will clean. So there is the improper communication. And sometimes the mismatched utensils. कभी किसी को मुकम्मल जहां नहीं मिलता, कहीं जमी तो कहीं आसमां नहीं मिलता. एक और एक कहना चाहूंगा, किशोरदा का एक गाना था, रूप तेरा ऐसा दर्पण में ना समाए, बेस तेरा इतना बाउल में ना समाए. Thank you. So और मैंने उसको खराब कर दिया. So this is the again some doctors in periphery, they are advising to fill up the syringe with the warm water and actually to push, but patient himself or herself cannot push, so they have to take the help of some attendant or assistant or better off. So this is what we have come across. And one more innovation is there, thanks to Bhaijan Sallu Bhai, who has come up with this new innovation. I'll just show you how the seats bath is innovated by Salman Bhai. Awaj? Wait. Okay. आवाज चालू करो. क्या करूं? म्यूजिक आवाज आएगा अभी? This is the innovative idea for seats bath given by Salman Bhai. अरे यार. This was the practice people are doing in some Vidarbha doctors. I have came across with the patients कि भाई तू कैसे करता है, क्या क्या एडवाइस दिया. बोले सर तकलीफ तो बहुत होती है, उकड़ू बैठ नहीं सकता. He had knee pain, knee joint pain. तो बोले टॉवेल गर्म पानी में भिगाना और ऐसा ऐसा करना. So this was the innovation. This was the innovation by Salman Bhai. I have come with the new innovation. This is the seats bath fountain. This seats bath fountain first I innovated in a decade back, 2012, and first I presented it at Kausani Dr. Ladukar sir, Dr. Chivte sir, Dr. Dinesh and I was there. So our mentor Dr. Chivte sir has promoted me कि this is a very good thing and you should work on that. He has given me some tips and bits. So we have come across, and this is a seeds bath fountain. I'll go into the detail of this. This is made up of stainless steel. It's a stool that's converted into a splash of fountain. This is a stainless steel. This is more useful for the hospital patients, while the earlier which I shown was of a mild steel, that is to say iron. So this is for the prescription to the patients. This is not for longer use, because the iron gets rusted after a certain period of time. And we have come with the new model also. This is a chair. This is for affluent class people, or for keeping in the hospital, or those who require larger area for their sitting. This every unit has been tested for the splash height and the force, and we have taken all care to prevent the electrocution by putting the miniature circuit breaker. MCB has been put over there. This we are supplying to Pune Healing Hands Hospital. This 12 उनको चाहिए.
Is it for patients or otherwise also?
Sir, this is to keep in the hospital. They like
Other patients who are not, having any wound, others also can.
they can also enjoy the hot jacuzzi, sir. This is this is a hot jacuzzi. Coming to the discussion part. The bucket is fitted on the under surface with the fiber sheet with the screws, and it can be supported with the velcro belt, what I have done. And it has got a submersible cooler pump actually. And the appropriate MCB, as I told you, is fitted over there to prevent the electrocution. And we have every unit tested for the physically for their height of splash and force. And the pump can be fitted to the bucket with the vacuum pad or aerial light or MCB, whatever, MCL, whatever. This is the inside structure of the seeds bath fountain. Now this seeds bath fountain, as I told you, was designed by me in 2012, and after the motivation of Dr. Chivte sir, we have gone for presentation to this Chennai, and there we have got the silver award as a National Medical Innovation Award in 2015. Also, with the improvement of quality, with the ongoing improvements, this seeds bath fountain has received ISO 9001 as a quality certification. And this is a patented product for India, so only we people are marketing this, producing as well as marketing this. Thank you so much. If any question, I would like to happy to answer. प्राइस सर जो आयरन स्टील का है वो 2000 का है. इट इज़ अवेलेबल ऑन अमेजोन एट 2200, बट वी आर सप्लाइंग एट 2000 एज ए होम डिलीवरी. स्टील का जो स्टूल है वो 2600 एट डोर स्टेप डिलीवरी, बट चेयर इज़ 3500. इट्स विदाउट कोरियर. वो कोरियर चार्ज अभी कैलकुलेट नहीं हुआ है चेयर का. 26, 35 एंड 2000, दैट इज द चार्ज. इलेक्ट्रिक सप्लाई. No, no, no. You have to put warm water into the bucket. Like, yeah, it's a splash. It's a current shock-proof splash, and the height of a splash and force of splash has been adjusted every unit.
Hello, actually, all kudos goes to Kodwani. He's my neighbor actually. We had done our post-graduation at the same time in similar batches. He's a very innovative person, but whatever he had, the modulations he has given previously, some type of chair were available, but that were not up to this level. Now Kodwani, my suggestion is there should be some improvement again.
Definitely, yes, there is a scope.
And that improvement needs to be, now you are putting a warm water, so warm water has to be done manually. You have to maintain the temperature 50 degree. Now you should have the coil inside. That coil will maintain the temperature not more than 50 degree. So that is difficult, I suppose, that can be done by you. So it will be absolutely innovation throughout. So that patient will just put a button, पानी टाकला तिथे की just he will sit and within 2 or 3 minutes and that warm water will maintain the temperature of 50 degrees. So it will have a cut-off circuit also. It will cut off when it will go above, and so that will be a newer addition. Then you can increase the price also. What I feel, if you because this was said to someone to me also. They asked me, what is the difference? पानी यहाँ से यहाँ डाला, घमेले में डाला का नहीं यहाँ डाला का, ठीक है मेरा स्पॉट है वहाँ, तो बोला ये चाहिए उसमें. So this is my request.
I'll reply to this. Sir, you wanted to say something?
Actually, I am ready to suggest.
Sir, please.
I have to do nothing. Here, basically, what you should do now, when you are putting a fountain, it should be a singing fountain. and put that Salman Khan song there. So it will be wiped also.
Great.
With this thing.
Great, sir. Great, sir.
Very simple suggestion. You will agree with.
Great, sir. Great. Sir. Yeah, definitely, sir. या मैनुअल में एक तो आपको पंप करना पड़ता है. ओल्ड डेबिलिटेड पेशेंट दे कांट डू. सेकेंडली मैनुअल जो प्रेशर है वो कितना देंगे आप, कितनी देर तक देंगे, यू टेन टू टायर. एंड मिनिमम 10 मिनट्स तो भी अपने को स्प्लैश देना ही है गर्म पानी का. सो दैट इज द डिफरेंस. जस्ट सिट एंड एंजॉय द हॉट जकूजी. दैट इज द बेसिक एम ऑफ दिस. Now coming to Dr. Ladukar sir's suggestion, I am very happy to share my view. My R&D team is already working on that. The product which I have shown here, this product exactly is available in China at INR 12,000 rupees, which we are selling at Amazon on 2200 और स्टील का जो 2600 में है या चेयर 3500 का है. चाइना में 12,000 INR का है. नंबर 1. नंबर 2, एज फार एज यू सेड कि हॉट वाटर का कुछ प्रोविजन होना चाहिए. अब मेरी R&D टीम वर्क कर रही है उस पर. द थॉट प्रोसेस वाज गोइंग लाइक कि इफ यू पुट सम हीटिंग कॉइल ओवर द हीटिंग फिलामेंट ओवर देयर, व्हाट विल हैपन आफ्टर सर्टेन पीरियड ऑफ टाइम, हीटिंग कॉइल के ऊपर कैल्शियम क्रस्टेशंस आते हैं. नंबर 1, यू कैन नॉट चेक द हीटिंग पॉइंट, यू हैव टू स्टॉप इट. नंबर 3, इफ वाटर इज लेस, दैट वो जो कॉइल है वो ब्लास्ट होता है. आई एम वेरी हैप्पी टू अनाउंस that my R&D has came up with such a heater that is temperature maintainable, as well as there is a thermostat. temperature 30 डिग्री सेंटीग्रेड पे हमने वर्क किया है, because 40 डिग्री के बाद आप 40 डिग्री में नहा भी नहीं सकते. You need warm water. 37-38 डिग्री पे usually people take the bath, and for anal area 30 degree centigrade we have worked on that. We have got the heater from Delhi, but still the work is going on. उसमें thermostat भी है, temperature setting भी है. 26 to 35 डिग्री टेम्परेचर का सेटिंग का हीटर हमने मंगाया है. एंड दैट टू, दैट हीटर इज enclosed in a glass sheet, so no question of calcium crustation, no question of current is there, and this is what our future plan is.
Thank you very much.
Thank you so much. If any more question, sir. Bathroom is the best place. They have to adjust. They have to put a curtain, or they have to. That they have to find out, or they have to ask their family members to stay away from room for 10 minutes. That's what. Okay, okay. See, what happens in case of fissure, cloth on is okay, but when you operate a fistula, you need actually some warm water to go inside. If you simply a person sits in the bowl, the water is non-moving, it's a static water, you need some splash to go inside. So this one, my innovation, is better not only for fissure or hemorrhoids, for better for fistula compared to other available kits. So splash is good. As I said, we have tested every unit for the force as well as the splash size and the pressure also. So this is the better one, I can say. Thank you.
Thank you, Dr. Kodwan.
Sir needs no introduction. Every proctologist, at least in India, should know him and must be knowing him. He is the president of the International Society of Coloproctology, and we are indebted to him by more than one way. One is, of course, the transanal suture rectopexy. Another is sacral fixation for the prolapse, which he has shown yesterday. Dr. Ladukar and Dr. Rajpal operated one patient yesterday by that method. And he'll be talking about another innovation. Yes, sir.
Full stop, okay?
Yes, sir.
I'll complete. See, it is not very easy to talk when a great teacher has spoke to you. Not only that, she has confirmed 79 times, asking, okay? So whether it has gone in your brain or not, she wants to confirm. 79? Yeah, I counted it. Next time I'll record it. Then second one, great entertainer, salesman, and we cannot compete with him. I am a speaker. I'll speak. Whether you take it or not, understand or not, I don't worry about it.
Very bad strategy.
Yeah, bad things are always accepted first. You know, this is the nature of the human being. You ask anything, they will remember Ravana first, then Ram. So bad things are always accepted by the good people. So let us discuss. See, so many procedures for the fistula, so many methods, classifications, everything has been already we have learnt. There is nothing to be learned in that. But this is something, different. Then you said, when so many things are there, why you are doing something different? That is a different question for that. But let me tell you, now if Govind is there, he would have said, Kisi ka dard le le udar, Raj Kapoor ka ana bol deta tha. I can't sing that way. But at least we should understand others' pain, If you understand why other people are getting pain and how we can reduce it, I think that is the greatest thing. Even Gita has advised it. Endoscopy use is basically, at least I have started using, it should be a painless procedure. Then I use for so many things. Today I will be talking only on complex fistula. You can use in perineal abscess, fistulas, sinuses and so many things. Now, we need not to, learn something like a teacher, basically 1, 2, 3, 4. No. This is only simple, classification of fistula. Simple, which is very difficult to understand as a simple, but still we call simple, but they are 75%. Transsphincteric and complex and so many things, if you come together, they are about 30%. So my friends, whatever we talk, it is less than about 20% or 30% cases. And basically we are worried about them rather than straightforward, a 5 centimeter long fistula, you can remove it, cut it, having less than 30% of external sphincter involvement, you can do very easily. And you can understand with this all pictures, whatever is given in books, and understand what you are doing at present. If you do all procedure take together, we do nothing, excise, incise, cut, remove, all these factors what we do. And I don't know what happens to patients. Particularly we are, I'll tell you, Anjali is late, so I can tell you one story also. One of my friend who was ACP in jail means he was in charge of jail, not he was in jail. So I operated him for fistula, very big fistula. Then we kept on doing dressing as our old thinking. We used to keep pack every day. Our thinking is like that. Nothing should be left behind. It should heal from the bottom of the wound. Bottom to hai, but bottom of the wound. So we used to pack tightly, regularly. That fellow used to bring at least 4 police with him. And they all used to come in theatre. I said, "Kyun laate hai bhai usko?" He usually said, "My friend है तो चुप बैठना." ठीक है. So many days it kept on, you know. So when he became all right, that time he opened his mind. अभी बताता हूँ तुमको, बोले ये 4 लोग क्यों लेके आता तुम? बोला हाँ अभी तो बता दे भाई. अरे तुम उधर जो कुछ करते थे ना, इतना तकलीफ था, ये 4 नहीं पकड़ते थे तो लात खाते थे रोज. मैं बोला ठीक है, अच्छा करता था भाई, उनको 4 को लेके आता था. बोला अभी और एक रिक्वेस्ट है तेरे को. बोला बोल क्या है? तू कभी कभी जेल को भी विजिट करेगा क्या? बोला अरे अच्छा उधर भी पेशेंट है क्या? नहीं पेशेंट नहीं, कभी कभी हमारी 3rd डिग्री कम पड़ती है तो तुम आते जाना. I said, then I really started thinking, if what treatment we are giving is a 3rd degree for my patient, whether it is worth giving. Since that day, you are seeing these wounds which are created by us, and then what happens to patients? They have large, wide excision as if we are treating a cancer, and we are thinking of a cure. Big pain we will give regularly. Sometimes wound heals. During healing we get good abuse. And if they don't heal and have recurrence, you get legal actions also. So this is what my patient described. It is 3rd degree punishment getting dressings from you. And they search some way, you know. If more burning is there, they want to cool it. And that's what they used to do it. You will say then what we should do for the high fistula and other thing. I am not going to read all this. It is only basically to show. I am not like Mrunal, you know, keep on reading everything and I'll fix it. Okay? Gaya andar? Nahi, jarur nahi usko. These are the again primary repair and other thing. But one thing I'll tell you, contradictory to this all figures, whatever I given here, there are really good papers which are published where incontinence is improved after repair. Few papers. Whether to accept or not does not depend on one paper. This can happen with the stress incontinence, even though you are normal at time. Now what we should conclude all that? Our surgical management of the complex fistula should have representation, having a fine balance between recurrence and continence. You will prefer recurrence than incontinence. So this is what we accepted. And up to date it appears those who are operations having preservation of the sphincter, that is non-touch techniques of the sphincter are accepted by all. You will say, you are talking new in this. People have already talked, they have already published, they have already made money on that, though procedure is not much useful. So that's nothing new. This I am not going to talk about 5 centimeter. These are the few instruments what we use for the fistuloscopy. I don't use a very sophisticated, something like 7 lakhs rupees instrument. I regularly use operating cystoscope, a telescope of cystoscope, which are 0 degree, 4 mm, which gives 100 times wider image than what you are getting with 0 degree optics. So 10, or that is probably 0.8 only, and all other dilators and other things what we used. These are the instruments what I use. I think you will see some instruments I stolen from the gynecologist. Some are with the surgeon, but some still again from them only. Now this, particularly I started. This we started in 2007. I presented and started in 2007. These are the PCNL instruments borrowed from the urologist. Probe we put in the fistula external, and then we try to dilate the fistula. And then after that, we tried to see inside. This fistuloscopy was started by us in 2003. And first time doing fistuloscopy, we found that we have teared a fistula at many places. And when water was going or saline was going, it was having edema around it. So what happened? I'll not show you all this picture, but with PCNL, these dilators, big problems were there. Injury to the fistula was there. Fistula was ruptured at some places, and perfusion of irrigation around the buttocks. If you see where fistuloscopy has done, that buttocks has enlarged nearly double than others. So next day patient can understand that. So with this all, we nearly stopped. We changed strategy. It was big failure for us doing this thing. Then what we started? We started dilating only external opening. And then we used to put scope inside and let irrigation fluid dilates it. And it dilates it according to its capacity, not beyond that. So for that also, we made a provision that we dilate this external opening little larger, at least 2 mm, 3 mm larger than your scope. So scope will not tighten for that, and this tightening will not balloon the fistula. So that has worked very well, and then pus and irrigation fluid used to come by the side of the scope. You can see one of the picture of just scopy. I am not, You are seeing all infected tissue. You are seeing like a velvety tube inside. This is only because of 4 mm fistuloscope. This is inside. You are going, and you can see abscess cavity in, pus is there, and all that you can be seen. And I think when you are seeing inside, you will enjoy it. This is the interior of fistula, earlier was not shown. And we usually try to find out inside. You can see we are going up to supralevator space without much problem, without cutting anywhere. So all this, you can understand what fistuloscopy can show you. So next we will go. Yeah, it's same what I have showed. You think I want to use something different than what I showed? No, I show exactly what I used. Means I don't have any other instrument, I am sorry. So, in fact, that was hysteroscope, not cystoscope. Hysteroscope's operating element. This fistula journey started from the pus, from the abscess to the fibrosis, what you are seeing, and everything was recorded by us on that. Sometimes epithelium or lining of the fistula inside can be seen in various forms, like a tentacular or polypoidal tissue. And this variation, velvety you have seen earlier, I don't know due to what infection, what we tried to collect it, culture it, but I did not get answer for that, why difference of this type of epithelial or tissue is there. So, but variety what we got, we have showed you. Then we started doing this exactly where is internal opening. You are seeing very easily seen. Many times you may not able to see it. जरा हे करून टाक रे. Then आवाज कमी करून तिकडे कर. These are the fistula tracts where you are seeing two tracts are there through single side, another fistula side going inside and inside. Then different of the, see we first time described extrasphincteric fistulae are round in shape. Round means not exactly circular but roughly round. And intersphincteric, all fistulae, they are almond shaped or oblique. Means even you on seeing inside, you will see whether you are in intersphincteric space or intrasphincteric fistula. So this all we describe in our papers. This is another picture I want to show you. This is supralevator fistula, where you are going supralevator, you are seeing inside that hole is there, puborectalis muscle is there, extrasphincteric muscle is there. And this triangle exactly shown in anatomy, I put that picture for you. This is in extrasphincteric fistula, what you are seeing. You are seeing clean, after curating this fistula is very clean. You are seeing two holes. It has got at 9 o'clock opening, one limb was going high up, second limb was going down to the 6 o'clock position. Now you can see through one hole, you can get these both tracks without much problem. And you can approach them without much problem. But people think, having two tracks, go dig down, up and out, not necessary. If you are having scope inside with you, now this is other track, what you are, I was telling you, intrasphincteric tract. Why they are, almond shaped or oblique these things? Because they are circle in circle. When circle in circle is distended, you get oblique or almond shapes, what you are seeing. These are all intersphincteric tracts. And this is also not described earlier. And we have now described all this. And you can see scope also identified. This scope has gone not beyond the 6 o'clock line. So this is intersphincteric, at least approximately. Now we'll take an example to show you or suggest you how we can treat a complex fistula. A female of 31 years old, good dancer, let me tell you why she came to me. Good dancer. She was operated earlier, drained earlier, recurrence earlier, and then she had and very complex fistula with abscess was there. And ultimately, I don't know, somebody suggested you go to this particular person. He operates without cutting anywhere. So she was also doubtful. Operation without cutting is what he does. Whether he has got, magic wand to just touch it and cure it. So she came to me. We saw her, described everything on paper. And you will see routine investigations. I need not to, again, go 1, 2, 3, 4, 5. You know everything about it. And after that, this picture was there with us, with the MRI. In yellow area, pus was there. That round what we have made, it's an opening there we have made. Intersphincteric tract was there, going again at 6 o'clock position and going to the supraelevator region. Such a position she had on MRI. This was drawn from the MRI. See, usually we had actually my son is a radiologist, my daughter-in-law is the radiologist. So we have made home team of radiologists to make me understand MRI. Other person like me cannot understand MRI or CT. So 2 people have been kept for that. So this, Now, what procedure actually we did it? As usual, what you used to do it, we detected internal opening, dilatation of the external opening, which was present there. Second external opening we made into the abscess, incision drainage was done. Curating of all the tracts we did. revision fistuloscopy was done, whether we are curated properly or not. We did fistuloscopy of the abscess also, whether we have curated whole abscess or not. And actually, curating abscess is very easy. And it indicates whether curating has done properly or not. Once you take curating in a kidney tray, you will find a fat globules there. Once you find fat, that means you have curated abscess very well. And this abscess, you need not to even drain it also. But still, according to, I cannot go against all principles of surgery, so I put Foley's catheter for a day or two. And once I see water is not going much, then I remove that Foley's catheter. So this all things was done, but slowly I will show you one by one. Dilatation, I need not to again repeat same thing. We use saline as irrigation, and we have a pump on the saline bottle which can give pressure to us. And once pressure, but we keep very moderate patient, about 50 to 60 milligram of Hg. We use the scopes. Now this is the practical picture. You can see about external opening she had, another opening for the abscess we made here, and then we started putting our scopes through all these whatever openings we had. This is anterior fistula, what you are seeing, same patient. We have put the scope from the upper opening, anteriorly going across the anal canal, and this is posterior, where abscess was there, it was going posteriorly below the anal canal. This is right from the external opening, externally going to the posterior, whatever pus was there. And earlier I showed you one picture where it was going to intersphincteric region. Now, curating of the abscess and this thing was done. You can see large amount of curating material came. So this all we drained everything and washed, cleared, scopy was done. Want to see how much curating was done. So curating I did not do. What I was showing, fat globules you will see once abscess is curated totally. Can you see it is a floating? Otherwise, our curated material always will settle at the bottom. If you see this, that means you have curated that abscess completely. If you have completely curated fistula which is not matured, that also will give same reason. Now, how you can find out yourself on scopy, you have curated everything. You are seeing now red and all those epithelial tissue, you are seeing totally white. And somewhere, you can see reddish. And one more you will see, there are shining, surfaces are there. Why those shining stars are there, Those are globules which hits light to them and you get that type of shining stars. So, that everything makes that fistula is curated completely. Now what we should do? Anjali, welcome.
Sir.
Congratulations. She has been declared Woman of the Year, and we should give a big clap to her. And actually, I have little objection. They have declared Woman of the Year. No, she is young girl of the woman, a young girl of the year. And because, she doesn't, activity suggests the age of the person. If a person of 25 sits like that and says, "Kya karo?" Usko kya bologe? And activity like Anjali, what she does, वो 25 नहीं छोटी है उससे भी. Facet तो है लेकिन age देखो ना भाई. Day by day she is becoming young. Congratulations. Thank you very much. Okay, I'll try to, compete with her now. Don't worry. Okay, now once we have created this type of tunnels, then usually I used to keep it like that only and used to give wash by putting infant feeding tubes regularly. They used to heal also, but they used to heal little delayed. Sometimes some muck will be there inside, or sometimes collection will be there. So then I started, putting collagen for packing inside. It is a porcine, a cellular, dermal, matrix, whatever names you want to give it, but it is a collagen developed from the intestines of the shapes, skin, tendon, vascular organs, whatever has been. I don't want to go in detail manufacturing. But this is having good fibrotic tissue which can give you stimulation plus a packing material. This is when you are seeing a fistula which is healing, you are seeing that around it nearly it heals. And there are fibrotic remains. That means that fistula is healing, not healed. Now, we would like to show you what collagen, what we do it, This collagen sheet comes as a avascular or not avascular, dehydrated, packed with the alcohol, isopropylic, that we have to wash it. If preservative is there, this collagen will not be expanded or used, that will remain as a foreign body inside. So you have to wash 3-4 times in a normal saline, then this collagen can be packed inside. It becomes pliable and very elastic, not like a fistula plug, very hard one. Now you are seeing, we are pushing collagen, no special instrument is required. You can just pass through the fistula hole and just keep on pushing it with the little broad dilator till the apex of the. If you have very large fistula, long fistula, sometimes this dilator may not reach. So you can put half circle urethrotomb inside and then pack with that. So that also we have tried it. So now this is packing, I think. This is anterior fistula what that lady has got. We are packing in her. And once this packing is done in all fistula tracts, and I can tell you statistically, this is in posterior tract. Why I am showing you all? Because you should know why collection is reduced by this packing. And this packing does not give pain to patient. Okay? Now this is particularly intersphincteric fistula I want to show you. See, this is not going beyond the down the sphincter, 6 o'clock position. So this is intersphincteric fistula. And I identified only on the scopy, it was almond shaped. Okay? So this we are, now I also have it of asking you okay. Sorry madam. I am not copying here, but still, lagta hai aisa. Okay, this this is one fistula where I use laser. This you are seeing pus inside, and with that pus we have gone deeper down. Now you are seeing that puborectal is there. And beyond what picture I showed earlier, that was fistula there. And this fistula was not coming in my curate and will not come in curate. That's why we use laser here. Now you will see how we put laser fiber there. Don't think every fistula I use laser. No, I don't use laser. Now we put fistula fiber into the ureteric catheter so we can identify under the cystoscope or scopy. Now you will understand what we are doing. Now this laser fiber will be emerged outside and that will be pushed inside those fistula, not anywhere else. I don't want to, treat other fistula with the laser. See, this fistula, they have 2 holes inside where my curate was not going. Okay? Now that has been coagulated. This is 980 fiber. That works very well on the tissue. And now you are seeing that tissue is totally coagulated. Not only coagulated, that gets stuck to the burning point. And now you are seeing that one fistula has become nearly, 2 fistulas have become nearly 1. And you are seeing muscle wall. You are seeing puborectalis and pubococcygeus underneath. Okay? You got the point where everything has been cleaned up that fistula. And now you are seeing that tissue with the burning. It can be washed also, but it goes with that too. Okay? Now we close internal opening judiciously. If probe is going, we go around the probe. You will say how we can go around probe. It is not easy. I use 2 needle on a one vicariate. Take inside suture first, second outside, and then tie it. So it becomes easy. So it becomes a circular. If you are directly suturing, it will get cut through. So it is better we do that. Now this is what happened. What you are seeing, grey line, green, that was abscess, and those pictures are there. Now this is after 3rd week. Nearly everything is healed. Everything healed. This is later on in 4th week when we have taken picture, and being a dancer, I could save her buttocks, because dancer cannot dance with one side. She has to dance with 2. What are the results of the endoscopy with the collision? We are doing last 3 years endoscopy with the collision. Recurrence rate about 9 cases, 11%. Required segmental cutting, means some fistulas are curved and there our scope doesn't go. We cut it. Now basically we are cutting those fistula which are at the 6 o'clock position. I need not require endoscope there. I can palpate it in duration at 6 o'clock position. I cut open, so that will cut to the internal opening, and we curate and close it there. Rest of things we treat as a fistula. So similar results are there. No incontinence developed, and pain was a minimum factor. From 2nd day, patient could go home and for the work. This is one just, casually I am showing you. It is abscess, gangrene, fistula, all 3 together. So what you are seeing, this gangrenous scrotum is there because patient remained at home after having abscess in the groin region for a long time. Now, anyway, openings were quite big, so we didn't dilate or anything. We curated. Those whatever fistulas were there, anterior plus longitudinal. I'm just showing you representative picture. As a surgical principle, we excised whatever gangrenous portion of scrotum was there. One side fascia over the testis was a little doubtful, but as the testis has got good blood supply, did not remove that fascia, I kept it like that only. Now you will see that both testes are hanging, curated, all material has been removed. No muck or no necrotic tissue was there. Now we put collagen inside a fistula where anteriorly going, and we close the track after putting fistula inside. Collagen inside. Longitudinally also, inguinal canal, we put collagen in that. Here the fistula opening was there, that also we closed. And you are seeing that. Now higher up, we are putting into the inguinal region this collagen. Down we can do, and we are putting Foley's catheter on that because abscess was there. So whatever collection extra, and that will hold the collagen also. That was our purpose, because this opening we have made very big. So these are few things what we are. Foley's catheter also we use it. Now we are seeing the wounds. I cannot tell you duration of each wound, but what you are seeing serially, I think you will appreciate. We have done no plastic flap. We have done nothing. आजकल वो मोदी साहब बोलते हैं ना, शुगर कारखाने बढ़ाओ, शुगर कारखाने बढ़ाओ, वो जैगरीला के हमने अप्लाई किया उधर से. And you are seeing till even fistula healed and scrotal wound is healed without doing any plastic procedure. Madam, I was telling you. So, if you compare with the WAFT, since 2011 we are practicing, it is similar method, scope is smaller, and that is fiber scope, not rod lens. Our cystoscope's 4 mm is a rod lens, which has got better durability and better visibility than that one. From May 2006 to 11, this statistical data I may not give, but WAPT's results from the Poland hospital, not mine. I never do WAPT. On the contrary, day on which WAPT came in Delhi first, I seen, their paper which is published earlier. And I immediately answered that paper to techniques in coloproctology that, sir, whatever you have published is not correct. In WAPT, you are not suggested anything for the curved fistula. On the contrary, fistula tracks, they are in funnel shape, this thing. More of the tracks are curvilinear. Second thing, you have suggested electrocautery for the destruction of the epithelium, which is incorrect by science, because it gives at least lateral damage 2 to 3 millimeters. And this sloughs after 2.5 or 3 months. That's why that fistula will not heal for 3 months, because that sloughing starts after that. And after that, when it will heal, you don't know. Same results. Poland people. See, industry, when it does, their results are beautiful. When Minro published, but he also published 57% healing results. About 30% patients abstained from the follow-up. We can't understand or what? Why judiciary we are following? We are calling by mobile. Are kya ho gaya tera bol aake dikha mere ko. And in this era, telecommunication is there. They should. But their patients are absent. You will forget from that paper, they have admitted these patients. 136 patients they have admitted. But data is given. Not admission data. Admission data is given of 93 patients. How you say 136 patients? So all these queries I put and sent to techniques in coloproctology. And they are accepted. And that paper comes now. Whenever anybody writes paper on the WAPT, that paper comes with that. So people should understand. And healing rate and other thing. See, I can talk anything, I can tell you anything. But best thing, घड़ी का advertisement है. इस्तेमाल करो और फिर समझो क्या है, ठीक है? So you should use it and do it. So all this video assisted and the thing I given this, I told you about the comments what we have written. They are published also very with broad heart and everything is. And healing can be having different times, right? Maybe from 6 weeks to even 2-3 months also, depends on size and length of the fistula. Difficulty in curating comes with this. I'll not say everything is very easy. Then what we should do? We don't have flexible curate, isn't it? Once we don't have flexible curate, fistula which are going around the rectum, posterior to other side also, your curate doesn't go. Curate can go up to one side. We developed. Again, gynecologist से चुरा लिया उधर से. This is suction DNC instrument. Okay? We took this, we cut it open, we connected our Rice tube and made a new suction curating. And this we started using. And now other side of the, if my opening of the fistula is on one side, we can go to other side. Because anteriorly we can go other side, posteriorly we can go other side. So it becomes easy for us. So this is what we did. We are using suction curate, that I don't think we should show. So present treatment of the complex fistula to me, I am saying particular to me, I am not saying it is widely used. Identify internal opening, dilate external opening, do fistuloscopy, curating, repeat fistuloscopy. Big abscess cavity, curate it, visualize it, put a Foley's catheter so it will reduce in size. You can inject sclerosant, foam sclerosants in the fistula tract, they can heal prosper and pack with the collagen. They will have minimum discharge, use infant feeding tube inside for washing. Normal saline can be used. Injection of sclerosants if you feel wide it is. And you can use collagen particles which are available now. Along with the sclerosant, mix with that and inject it. So they will heal also. So when these fistula are not healing faster, you can use all these things. Sclerosants, I think everybody knows how to make it. Yesterday also showed it. This is to his procedure. And I think everybody can do, everybody can use it. And now this is injected in one of the pyloneural sinus, what you are seeing it. So I am using for everything. Let me tell you, I am a very lazy man. I don't want to exercise anything. I just curate pyloneural sinus, inject in that pack collagen, khatam hua kaam. Now you will say, "Arey, tum wo natal cleft ko kya kar?" Yes, I do with natal cleft also. I open natal cleft with the arctic lamp, make a big pocket, put collagen there, 2-3 pieces. So natal cleft is, I'll show that paper sometimes. That natal cleft is also reduced. So your all problems are solved with the pyloneural sinus. That sometimes else we can talk about. Conclusion is of course painless. All infected granulations or whatever 10% are there. We excise 100% of fistula, perineal abscess, simple fistula less than 5 centimeter. We do DNC, but I have not mentioned here. DNC means dilate the fistula, curate everything, close internal opening, pack with the collagen, or don't pack it, wash it. That heals. You don't have to do fistulotomy and fistulectomy and create, oh, key ne hota hai kya, lock hota hai kya, malum nahi. Key hole jarur nahi, lock ka bhi jarur nahi hai. It heals. Only if that fistula is very solid, excise. Pyloneural sinus also we do with this. If possible, without any cutting, no painful dressing. Healing is in shorter period, sometimes 3 months also. Patients are happy to get it repeated again. My friends, I told my patients, 2 or 3, few patients, I could not cure them. After 6 months also they were not healing. So I said, no, now I have tired. You get it some. No, sir. You repeat it again, we are ready. This is your victory, nothing else. When patient is not healed, when patient is not cured, he tells, no, you do it and you do it same thing again. Because he was repeatedly operated 3 times, cut with big wounds, and he knows what is the agony of those wounds. So this is what you can gain it. Friends, practice, practice and practice. You will get good practice. Next, I need not to tell, good money also. Thank you.
Thank you so much, sir.
Govind, very nice question. I am not again industrial man. Collagen can come out itself. That is called extrusion of collagen. I have not described everything. My paper is very different. If this collagen is put in intersphincteric fistula or tract, percentage about coming out collagen is about 60%. If it is an external tract or in cavity, this extrusion of the collagen is very less. If you see extrusion of fistula plug is greater than whatever, but only intersphincteric I cannot, because fistula plug is not done in intersphincteric tract. They are with the extrasphincteric simple straight tracts.
So that was a really fantastic and thought-provoking lecture by you.
Thank you. If you have provoked thoughts, I am happy.
So no wonder, sir, I could not get any sponsor for Stapler, and I'm sure there will be nobody who will be ready for from the fistula plug also. Do anyone has an idea how much a fistula plug cost?
I have idea. Why you are asking others?
No, not 20,000.
60,000.
It's 40.
At this present, 60,000 it is.
So
anyway, you can reduce price to your mind.
Sir,
no
Dr.
problem.
Kale wants to have
I'm not
some
using
comment?
because this collagen material costs 1,000 rupees to you.
And sir, I want to. Yes. Sir, I want to ask you a few questions. First of all, like normally what we do is place collagen when there is when there is no infection. So would you like to first clear the infection, not only on table, after like cleaning it for a few days and then put a collagen in the next sitting? Is it advisable to or put in the same
patient
sitting?
is under anesthesia, you can push any way you like.
No, it's not about the pain.
Right.
It is about the infection. Like if
No, unless
like,
infected area, we don't put collagen.
okay,
Then you have to keep on washing and you be sure
okay,
there is no pus or no foul smelling discharge or some dirty discharge. It should be clear. Saline, if comes clear, you can pass collagen. But without anesthesia, passing collagen is not easy because patients will not allow. You are probing that wound.
no, you can
It is
always.
same thing what we are doing, poking your packs and packs and packs inside. Same thing happens.
No, that you can always do in the second sitting with under anesthesia only.
Yeah, sure.
Only
Then-
thing you should not put
yes.
under when there is a
Then
sepsis.
that time you curate it also, no?
Yes.
And you put collagen.
Yes, and
See, best tool in your hand is curate.
yes.
I'll not respect laser, I'll not respect radio frequency, I'll not respect even chemicals also. Sometimes chemicals are better, sometimes, where fistula is in corner going, tortuous ways and other thing. Because why? Why your Ayurvedic colleagues, they are getting better than you fistula treatment? Do you know that? They use liquid kshar for injecting in that. So tortuous way this liquid will go. They don't put kshar sutra inside, they put kshar.
Okay.
We should learn from them. We can use also some chemical, but I will not advise because I have no experience over that. But if you use curate judicially, that's why you have seen 6-7 curates I got it done. Because I don't know sharpness of which curate will go. So use another one. Get curated. Yeah, please.
Collagen sheets or collagen particles?
No,
Both
sheets.
you can get.
Collagen sheets.
No, both you are getting. Anjali, you
Sir,
can get collagen particles, you can get collagen seeds,
Sir.
seeds of any size.
Seeds are difficult to pass. That is why you require anesthesia. If you have particles, you can just inject with the syringe.
I agree with you, but they will come like that also outside. Collagen sheet, see collagen sheet, when you are putting in the, for example, close to the internal opening, you can take a bite through that, it will not come at all. And that gives second layer to your internal opening.
Sir, another thing is like you said to dilate the fistula tract. Have you ever noticed any difficulty in dilating the tract, especially if it is a thick fistula tract and long standing?
I am saying external opening, not tract. Only external opening. You see, I have burnt my finger after dilating fistula earlier.
Okay.
I don't want to dilate fistula. Let it be mature, very hard fistula, but only external opening you are dilating.
Okay.
And don't cut open or don't dilate with the artery.
Okay.
That will puncture your fistula.
Okay.
And then fluid will go around the tissue. Again, edema occurs.
Okay. Okay. Fine.
Don't be hurry in that. Slowly dilate. Hagar's is the best. And give gynecologist touch very nicely, slowly dilate it. So it will not burst. Mind well, should not be burst. You dilate up to 6 Hagar.
Okay. Actually, this procedure when sir started, I am a copy master of sir. Really, I put my everything for his every procedure. I try to learn it from my bottom of the heart and I try to practice it. Patients are there. So what I understood after doing so many of the procedures by keeping this everything what he has said, before telling you what I used to do or what I am doing, I want to highlight something, some important thing about fistula what I learned throughout. Still we are in darkness. We don't know what is the simple fistula and what is complex fistula. That doesn't mean that internal opening we have palpated at 6 o'clock position and the external opening is very close to the anus. Is it a simple fistula? The fistula tract, the outer opening is just 4 inches or 6 inches beyond the anus. Does it mean it is a complex fistula? आपल्या ज्या आयडियाज आहेत ना त्या इतक्या हे झालेल्या आहेत की we feel that the distance between the internal opening and the external opening is defining the complex fistula. Not like that. It is not like that. External opening pasna internal opening 6 o'clock, it is at 6 o'clock position and with very close to the anus, just beyond the intersphincteric tract, but still the fistula will be very, very complex. If you go and understand the anatomy of the fistula, Park has given very nicely, the tract of the fistula, not the internal opening, the tract of the fistula which traverses the external sphincter, that defines the complexity of the fistula. The tract which is going below the 1/3 of the external sphincter is simple fistula. If you put because the external sphincter is subcutaneous, superficial and deep. This is the part of the external sphincter. Now, the tract of the fistula which is going from external to internal opening, if it traverses above 1/3 of this external sphincter, is a complex fistula all the time. That is very mandatory. आणि आपण जेव्हा प्रॅक्टिसमध्ये बसतो पेशंट समोर तर आपलं लक्ष फक्त वी आर ओनली कॉन्सन्ट्रेटिंग अपॉन दिस टू दिस असंच आहे असंच टाकायचं आहे. दिस इज नॉट अ डिस्टन्स बिटवीन दिस टू एक्सटर्नल अँड इंटरनल ओपनिंग, but a tract from external opening going like this and coming into this in the same end and opening to it means very small distance also. Within a very short distance the tract may be very prolonged one, and that makes the thing very complex. Now, sir, if wrong, now the simplest tracts are simple fistulas are just lower 1/3 of the, if the tract is in the lower 1/3 of the external sphincter, then it may be a subcutaneous, it may be intersphincteric also, which can be dealt with by a simple fistulotomy or a lowermost. You can go for any of the procedures like lift, WAP, anything. But these tracts which are transsphincteric and suprasphincteric, the suprasphincteric, they are again divided into supraelevatoric and infralevatoric. So these fistulas are very, very difficult. Now you may go for fistulotomy. Yesterday we have done this surgery where this was transsphincteric tract and we sort out at all the tracts. I'll put an what are the some accidents which occur during infiltration of the H2O2, that I will let you know the house, because this is my experience. Let everybody should learn it, because one should commit, one should face it, but nobody should face it. Now, when we are stuck up, that is when we are not able to see. We are not able to see the internal opening. That is the complex fistula, most complex fistula. When you are not able to see the internal opening, you are from external opening, you are putting a H2O2 or a dye inside, but internal opening is not seen. Now, before that, I will again let you know my experience. Before just 15 days, patient was on table, very young patient. From external, I put H2O2 first. I tried to see, is it any spark coming from the internal opening? No. Then again 2-3 cc more. Then I took some betadine, diluted it with betadine with H2O2. I again put it. And then it could be 5 to 10 cc of H2O2 mixed with betadine. A normal patient, when everything was doing under spinal anesthesia, sudden started breathlessness. Sudden. Normal, she was having absolute, all indicators were normal. Suddenly she started breathlessness, dyspnea, and everything was very bad show. I just stopped it. It was the process of embolization which occurs during H2O2. Everybody should be very cautious. If you put it, if the internal opening is not there and it is not coming from the internal opening, or even if it is not pushed, it is not coming from the external wound, it creates a havoc. Positively, the patient was managed, everything was done nicely. So, again, this fistula, which is not having internal opening, becomes a trouble for us. So, this is the complex fistula. This procedure, what sir has shown to us, is a very interesting procedure. I have done so many of the complex fistula, but this fistula, where you are not able to locate the internal opening, this you can, कुठे जाऊन कुठे खर्चाटत बसण्यापेक्षा, you just dilate the external opening, not full. Sir used to dilate the full tract. I used to dilate on the external opening, put the scope inside, and with the water, only water, you press it, and it gives the direction, it opens the collaterals and then the tracts, and then you try to see where it goes. Yes, this procedure, by looking towards the tract, where you are reaching. So when you don't know the internal opening, in that place, this DNC, this fistuloscopy is a very interesting case. So you can go to the extent, and where if there is an abscess which is hidden. So many of the times I have seen that externally patient is very good, but there is an abscess cavity which is there in the intersphincter space, which cannot be located outward also. When we are not doing MRI also. Even if you are doing MRI, many of the things are mistaken on MRI. We cannot rely on the reports of the MRI. When we face the patient, something is different. At that time, this fistuloscopy helps us a lot. So we can go to the extent, and then the thing is just you have to curate it out. You may put the collagen inside, but again the complication of this procedure I will tell you, which I faced. If outer opening is very small, because this in fistuloscopy is very small, you're pushing your scope up to 3 to 4 inches sometimes inside to see the tract. Now what happens, if you are not dressing it clearly and you are not regularly actually putting a saline inside and you are not dilating the outer one, what happens, before the internal tract closes, the external wound closes, and then again there is a collection inside and the patient faces the difficulty. So the tract has to be drained for 7 to 10 days more. That you have to see all the time that this patient to be followed up very regularly. Otherwise, if the patient, you do this procedure and the patient goes home and it comes back after 15 days, everything would be spoiled. So these are some of the inadequacies, rather some of the discomforts are there. But if the patient is regularly followed up, and if you put the external opening all the time open, sometimes if it is very long, put a catheter, Foley's catheter you can put, and you see that the wound heals from inside out. So with a less amount of this tissue destruction, this procedure is helpful. This was my smallest addition.
Good. So do you get MRI done for all the patients?
It is actually, I have read about a paper where is a very good man, Dr. Garg is there, and he has classified it very, very nicely. He has given his Garg classification also. But when he says there is a complex fistula or there is a recurrent fistula, so what you should do first? Nothing to be done first. Even if you do PR and this is, he says, do investigation of choices, MRI only. And that to be in very good hands. Do MRI. Even what he says, that's absolutely correct. What he says that he does some procedure, tropies or whatever, even if he has done fistulotomy or fistulectomy. But he says that if the patient external wound is also healed, you have to repeat the scan. You have to repeat the MRI. Because externally patient feels that patient is healed, you also feel that patient is healed, but there is an inside silent abscess. So after healing the fistula, if your MRI says that everything is healed, there are again controversies how you can define in between the scar tissue and infective tissue. There are some opinions are different, but he strongly says that MRI should show postoperatively also there is a healing, then it's a healed fistula. So first is MRI, and then typing of the fistula in a classified way, in which category that fits. It is a suprasphincteric, infrasphincteric, subcutaneous, and then you should do the surgery. It is a bit difficult. So many times we are done, but still we are not able to understand how to draw the diagram of the fistula. It is again different because 3D मध्ये कसा काढायचा diagram, तो actual याच्यामध्ये कसा काढायचा. Still I could not do that very good. Might be somebody who is able to tell me. If you operate the thing, operation is easy, but how to put it on paper, it remains difficult for us. Sorry,
I feel whether you do MRI or not, first clinical examination and drawing your diagram is very important. If you don't do that, understanding of MRI also is difficult because we are not acquainted with that. We should get okay. Now they write in quite detail, they show diagram and everything. But you should confirm before MRI, and there is nothing much to be confirmed. If patient is not under anesthesia, he helps you. Once you put it finger inside, if cord-like structure is there, you know that it is a fistula going around. If at the 6 o'clock position you have induration, you know there is something wrong. It may have internal opening here. Go to the right. If it goes high above, ask patient, you get pain. Yes. Then you fistula is extending on that side. Left side you go it. So total digital examination for all fistula you must do. You must draw your diagram with that. Even you get 100 times wrong with MRI, first you try to draw your diagram with clinical understanding. Then only you can say what MRI is showing, whether I am going same way or not or different, that will give clue to you. If you are just depending on MRI and diagram aisa hai, you don't get anything anywhere. Even open. You must have heard my friend Parvesh Sheikh, udhar likha tha, udhar kuch nahi milta. Because he is doing open. And when we are doing inside, we don't require any description, you know. Supralevator, infralevator, nothing we require. Now we are talking because we see structure. Here, fistulas are classified only in 2 ways. Longitudinal, curvier. That's all. If endoscopically you are doing. Now, longitudinal can be described in other way. One is extrasphinctic and intrasphinctic because you can see difference between two. Curvilinear, always you can say anterior, posterior, antero-posterior or circumferential, that you can describe. But there is nothing because on endoscopy you cannot identify that. You can identify endoscopy with your finger manipulation. For example, you are putting scope on that, you put your finger on the coccyx, you know anococcygeal ligament is there, and then you try to find out how it looks. Nobody has given this anatomy endoscopic. Suprapubic also, supralevator also, nobody has given that anatomy with endoscopy. But anatomically they have given. Now you can see if suprapubic or supralevator fistula you are saying, if it is through the intersphincteric, your puborectalis remains on lateral side. If you are having extrasphincteric, puborectalis remains on the medial side. So these are the differences. You will find yourself and you will have your own marking anatomy rather than just depending on MRI anything. This is my personal opinion again. See, you have to search your path. I can't just become a sparking plug, not a fuel. Thank you.
I would like to add one comment over here. MRI as we talk, digital clinical examination as we talk, but as we know, MRI is a costly affair, and every setup, even in small town, there is no MRI available. But equivocal to MRI investigation, transvaginal ultrasonography in a good hands with putting hydrogen peroxide gives equivocal results of MRI on a lighter mode. Take it on a lighter mode. Sir is proponent of MRI left and right. Sir said clinical examination for fistula. For me, if your wife is radiologist, do MRI first before the surgery and after the healing also.
Thank you.
Hello, to moderate the session, may I request Dr. Hemant Patil and Dr. Sandeepa Samant? Kindly come. Shanti madam नहीं दिख रही. छुप के बैठ. Oh my God. Okay. Anyway, so may I request Dr. Anjali to speak on sigmoidoscopy. Everyone knows Dr. Anjali. She has just received one more award. She is in the habit of having awards almost a year. No. Yesterday she was felicitated for as a Medico of the Year award at Nanded, and still she got time to come here. She took train in the night. She and came in the morning, and directly she is coming for the show. Dr. Anjali is also treasurer of Masi. And she is very active member of MASI, and she is also active member of Venus Association of India and ISCP also. Yes, madam. Everywhere, she is everywhere, yes.
So, good afternoon, all the seniors, respected Chute sir, Secretary Dr. Ladukar, and the affection and love of ISCP family, you cannot avoid it simply. Dr. Thane, congratulations for the efforts you have taken, and that sincere efforts have compelled me to do. Congratulations. So, today's topic is rigid sigmoidoscopy. Everybody here must be performing the flexible colonoscopies. Some are having gastroenterologist in their institute. So most of the patients, they do colonoscopy, screening colonoscopy or diagnostic colonoscopy with the medical gastroenterologist, and then they report to you. Most of the surgeons are in the learning phase. Most of the surgeons, they feel why to invest so much in 7 or 8 lakh rupees for the colonoscopy. So there are multiple facets to it, but rigid sigmoidoscopy is basically every colorectal surgeon who is supposed to operate on fistula, piles, or for that matter any bleeding polyp, etc. You cannot go blind. And nowadays, with the increasing in the medico-legal issues, awareness of the patient because of the Google, you have to have some answers to your educated patients' questions. So this rigid sigmoidoscopy is giving you a third eye, that is one, safety of the operative procedure which you are going to do in the anal canal. So what is this rigid sigmoidoscopy is about? The indications are, various indications are there. Of course, it has limitations as compared to the flexible sigmoidoscopy, but it can solve much of the problems. Basically, the lower or the sigmoid and the rectal cancer can be ruled out. One, any bleeding tendency which is happening because of the ulcer, because of the IBS, because of the ulcerative colitis, or some entity. Suppose a patient has taken a 20 years back radiotherapy for the carcinoma cervix, patient has taken radiotherapy for some another lesions like pelvic tumors or etc. In that situation, you can have a safeguard in your hand. So investigations will be bleeding, and whenever depending upon the clinical features, you are suspecting some growth, suspected polyps or growth and change in bowel habits, and when there is you are suspecting genitourinary difficulties also, but patient has perrectal symptoms. Now the preparation for rigid sigmoidoscopy, in flexible scopy, usually we give a peg leg or exilite preparations. That takes lot of time. That is one. That makes patient more electrolyte imbalance. Third thing is, many of the surgeons, they think that anesthesia is compulsory for the flexible scopy. But here, what I have been performing rigid sigmoidoscopy since 2002. So what I have practiced is, patients have only taught me, this is basically OPD procedure. If patient is having severe constipation, you can give tablet Gerbiza, now called as, or Dulcolax tablet 1 day prior. That is one. Second thing is, if patient is having not severe constipated patient, depending upon the history you can decide. The patient when comes for the rigid sigmoidoscopy, you can give one enema, Proctology enema or the phosphate enema, sodium phosphate enema. Give it, patient will evacuate. After 15 minutes, you repeat another one more enema. Now, why 2 enemas we practice is, many of the time, even with the first enema, patient evacuates and the mucus secretions which are there, they come down into the rectum and they trouble you during your next scopy. So give time, after second enema, give 10 to 15 minutes to the patient. That will clear your rectosigmoid area. Now there are various companies have been manufacturing this rigid sigmoidoscope, but I have been performing with the Kalelkar's rigid sigmoidoscope, and they are handy, they are soft, they are pliable, they are non-traumatic, easily autoclavable, and their attachments are very rigid. They are not delicate. That is one thing, because the maintenance of rigid sigmoidoscope should be zero. if we do once autoclaving, then there should be no hassle. There are various companies which can have a light source attachment which can be very delicate, the air insufflator attachment that can be very delicate. So whichever I have found, that Kalelkar's rigid sigmoidoscope, they have various sizes from pediatric to geriatric, almost 5 sizes scopes are there. Now the tube length of various scopes is maximum is 30 centimeter and minimum is 20. Even 15 centimeter is also there for the pediatric patients. Diameter, inner diameter is 20 millimeter, that is 2 centimeter. So with this 2 centimeter, the advantage is inner diameter gives you a good biopsy channel, or you can have manipulations inside also with the rigid scope. Only thing is, patient should be given a good position. Second thing is, your light cable should give a good light inside. Third thing is, whichever you are doing, that should be it should not be devastating bleeding. Suppose if there is a wide based polyp, you cannot take it out, because you cannot have more than at least the procedure which is finishing within 10 to 15 minutes time. If you have a pedunculated polyp, yes, definitely like the extracorporeal knot, which you can push it through rigid sigmoidoscope and you can safely cut it. So you have to decide. All distal annular illumination for the total unobstructed view. Durability is, it is 100% autoclavable. So again it simplifies and it adds advantage over the flexible scope, because of which hepatitis B is rampantly spreading because of the not proper techniques of sterilization. At the end of the rigid sigmoidoscope there is a glass cap, and these 2 caps come with it. One is a simple glass cap which can have, if there is a excessive insufflation inside and patient gets discomfort because of your hand insufflation, you can immediately take it out and patient will feel okay once it is desufflated. Second thing is, when you want to go for a biopsy, there is a separate cap which has a small opening at the end of the tunnel from which you can put the biopsy forceps inside. This is actually the position which we give for the patient. Now look, this position of the patient is very important. Why it is important? It gives the basically the abdomen of the patient or the lower abdomen of the patient is going to decide whether your rigid sigmoidoscope is going to go inside or not, because your redundancy of the abdomen, if the abdomen is pendulous, your whole of the colon, it falls forward. The axis of the persons, it varies. So this position should be like that the pendulous belly should be supported by a pillow or the assistant's hand. That is one. Second thing is, the opposite leg, one leg should be straight and that should be supported either with a trolley or the stand, whichever is possible, and the upper limb should be flexed at the knee level and that should be taken into abdomen. This view is very much important. Now depending upon your comfortability, whether you can do it by standing or sitting on the stool, that will decide. Sometimes you may have to give a steep head low position, or depending upon your curvature, or if the ischioanal angle, you can decide that what should be the choice of the patient. Now before we begin, the trolley or the basic rigid sigmoidoscopic trolley, what it should contain. One thing is rigid sigmoidoscope, the obturator and the stellate, whether they are fitting properly, the upper end, whether it is soft or not, the insufflator, whether it is leak proof or not. If it is leak proof, just confirm it before, because once you put a scope inside, then again it becomes a hassle. And the xylocaine jelly and the proper pads, because you are going to apply jelly with your finger and everything becomes sticky, so you cannot hold the light cable inside your hand. Now shape of the colon. If you could see that the rectum, anal canal and the sigmoid colon, there is an angle. Again at the level of lower 1/3 of the rectum and the sigmoid, again there is angle. So almost maximum cases, although we have a 25 to 30 centimeter length of the rigid scope, and the advantage is that once you have 95% insertion of the rigid sigmoidoscope has been done. Again, beyond proximal to that, you can see 5 to 7 centimeter distal to that, because distension is there. So this is an added advantage. Now, what should be the direction of propagation of your rigid scope? This is very much important, and this actually threatens us that is there a perforation chance. So here the only precaution which you have to take is, once you do a PR examination, just while doing or application of the jelly, try to assess the coccyx angle. Try to assess whether it is too posterior, whether it is obtuse, or whether it is in the straight line. Once you define this angle, automatically you will able to see that how should be the path of the scope. Second thing is, if the patient has, what are the possible problems? Now, once you have inserted first 2 centimeter of the rigid scope and further scope is not negotiating, that means your direction is wrong and you are applying a force at wrong place. Now, here is a small video. First, confirm whether the proper obturator and the scope are fitting well. It should be non-traumatic. This is the light source cable. Sometimes there is actually, this is very delicate, so you make it sure that it is well fitting and it is not loose. This also should be fitted well, so that there will not be any leak while insufflation, and if the 100% insufflation air is not going in, you will not have adequate dilatation of the colon, and unless and until you have a proper distended colon, you cannot propagate ahead, because if you try to push without insufflation, you will touch to the mucosa of the patient and patient will get pain, patient will shout. So you should be in the lumen of the distended colon without touching to the serosa or the mucosas. So that is the crux of the procedure. While taking the biopsy channel, while taking, or while, if you want to apply the biopsy cap for that matter, now keep the scope as it is at its position, take out the first cap, insert the second cap, and by this way you can put your biopsy forceps. Now, regarding biopsy, what I can say is, if you have located the growth at the lower rectum or upper end of the rectum, you can keep the proximal end of the rigid scope actually over the growth. You can rest your scope over the growth and you can take the biopsy. That is added advantage which you cannot do in the flexible scopes. So, we have applied sufficient xylocaine jelly, lubrication. This jelly should be not only applied to the anal canal but the surrounding skin also, because your scope is touching to the skin around and that again gives a friction. So it should be smooth transit inside. Once you have inserted, the assistant will insufflate, apply the light cable. So this movement of propagation is very much important. It should not be blind. It should be 100% in the distended rectum. Unless and until it is distended, the walls, or which is the obstructing or redundancy of the luminal mucosa inside, will get obliterated and you can safely go within. So whenever your scope is not moving or obstructing, that means you are touching somewhere or you are in a wrong path. Maximum length of the insertion can be this much in almost 90 to 95% cases. Only thing is, you should have patience, go on distension. Distension should be leak proof, ideal position should be given. So possible complications with this procedure: there is low incidence of serious complications if you try to have a mirror image of anatomy or mucosa inside. 60% report adverse effects, but since 2002 I have not faced any of the adverse effects. 30% reports moderate to severe pain, and this is because of the extreme insufflation, and which you can take care of, that you take the cap out and gradually distend, do not take it immediately, gradually distend. 8% of the patient uncomfortable desire of defecation, and 4% they discomfort with the patient positioning. And bacteremia, if only and only if the patient is having suppose a diarrhea or patient's bowel has not been well prepared, in such cases only you have to take care. So be flexible with the rigid system, that is my message, and have no rigid system in you, because almost all of us have been adapted to the flexible scopy. All of us have performed rigid sigmoidoscopy, but for a newcomer or a new surgeon, he cannot have all the gadgets on day one. So this can add or this can give a third eye to a surgeon. Thank you so much.
Fantastic, Anjali. Few points. In your slides, you said there is moderate pain for the patient. I think you have got very soft hands. My patients will be very bad if 22 centimeter scope I am putting in OPD basis. Either their sphincter has to be too relaxed, either they are becoming relaxed by seeing you. My patients will not tolerate, I think so. No. 2 centimeter thick scope. I can use a pediatric rigid.
But pediatric scope will not give length in adult patients, no?
No, I'm just talking about. Yeah. So OPD basis is with experience you can do it.
Yes, definitely.
I am little worried about, because I got one patient who has got a vasovagal shock because of this rigid sigmoidoscope.
Arre bapre.
So that is happened once with me. So my practical tip is that if you are not well with the procedure, better to do all your sigmoidoscopy before your any pile surgery, before initial practice.
That can also
you get used to that, because that way I have done it. So you get used to use the rigid sigmoidoscope so that you can have. And another thing, she said, you don't know what is the curvature once you go to the sigmoid curve. So colonoscopy or sigmoidoscopy is like that. You come out, see the lumen, then go in, come out. So the maximum you come out, then the lumen will increase. So it's examination also is not while going in. While coming in, you'll have to examine. So that is one thing.
Sure.
Thank you. Thanks a lot.
Yes.
Now, I'm glad we are talking about rigid sigmoidoscopy, because as far as I see, it had completely, there were very few people performing it, because flexible sigmoidoscopy obviously had its benefits.
Yeah.
The only disadvantage being we require some kind of sedation or anesthesia with a flexible, whereas we can do rigid on OPD basis, like you're right.
No, now whichever, even I have shifted to flexible colonoscopy since 5 years, and believe me, we are not giving any sedation, anything. Within 3 minutes, our colonoscopy is done. So the thing is, this rigid sigmoidoscopy will teach you the anatomical turns. That is my message. This rigid sigmoidoscopy, you go on learning. It cannot be, we have a mental block. One patient gets pain and we suddenly stop so go on gradually. And one tip Dr. Hemant has told, that first we can do it under anesthesia. Try to, that is good suggestion. That is one thing which can be tried. Second thing is good lubrication, and proctoglyce or sodium phosphate enema, it again helps for the inner mucosal lubrication also. That is one advantage. Second thing is, sometimes the rigid sigmoidoscope, there is a AC in the OT and the steel tube gets very chilled. So that can also give a certain uncomfortable discomfort to the patient. When we put it inside, he feels very cold like thing. That can also be taken care of. And fourth thing is, do not go blind, go slowly. Once you see the road, go ahead. So that can be adapted, madam. And even with the flexible also, we have applied the same principle, madam. Come back, go ahead. Come back, 2 steps, come back, 1 step, go ahead. So that is the message.
Left lateral position, have you tried these patients in a routine position with a knee bend position?
Not right.
I find it is very simple.
Yes,
Okay.
it is simple. It is simple. It is in total knee bend position. It is very simple.
Very simple.
Even
It
you are
is
putting
very easy, because when you press the knee on the abdomen, your curve of the sigmoid may go.
Yes, and even with
Sometimes it's
even
very-
simple proctoscopy is also very good in that position.
But
This is
okay.
that is not
but I
described in the
feel
book.
ki patient gets embarrassment.
It is like that, whatever your personal experience, best for the patient.
Yeah.
And secondly, madam, I used to do it rigid sigmoidoscopy earlier, but now video sigmoidoscopy is also there in the market.
Yes.
But I feel doing all scopies like cystoscopy, bronchoscopy, laparoscopy, all types of scopy. If you challenge on, if you learn colonoscopy is most difficult to learn. The curvature is also long. Learning experience, it needs a long. It needs a patience, and to reach the up to the cecum in every patient, it's very difficult. So actually, she's master in that. She has learned from a very good mentor, and she's doing very regularly. I started it doing, now I am doing regularly, but it takes a longer time, from 45 minutes to 35 minutes, then to 20 minutes, when any patient. But if you are having that efficiency to do the colonoscopy, so I feel that even on the operating table also, you can
Yes,
do
yes.
colonoscopy
That
also.
is
There is
one
no
good
need to
suggestion.
have sigmoidoscopy has a very good, big disadvantage, because it is a rigid one. Sometimes if patient is not under anesthesia, patient will definitely have a pain. Routinely colonoscopy we are doing, I think, under no anesthesia. No anesthesia is required for doing colonoscopy also.
No.
Even no diazepam or midazolam is not necessary.
Not also diazepam or
Regularly
nothing,
on the external
that is
colonoscope, you have to
and only then and then it is
The
a
assistant goes on
affordable
putting that
procedure for
halogen
us.
jelly.
Then and then, because if
And
you are taking
everything is
5,000 from a
lubricated
patient and the 40% is going to
No.
so that is we should learn it, and we should have a
And a request to the house that if you are not doing any sigmoidoscopy or colonoscopy, you are missing your surgical practice. I tell you, the day I started colonoscopy, many of the patients like carcinoma, early carcinoma, and then so many of the patients were diagnosed on the table, and that they were then were turned into the surgeries. So many of the patients, if you do it regularly, many surgical cases would be selected out.
Same thing with upper GI. Unless you do regularly upper GI, you will not find hiatus hernia.
yes.
Same.
Yes.
And even simplest scopy is only endoscopy, upper GI endoscopy. Simplest.
Yes, simplest. Because stomach is quite big. So you
But-
can rotate the scope,
but
you can do
still-
anything.
But still, we have to learn it, how it is to be moved, because without any assistance, you have to go, and how swiftly we go, and you go to D2. So all scopies, the principles are same.
Yes.
Principles are same, but still, colonoscopy holds a bit. It is a bit difficult. It is really difficult. And sometimes patients, those who are irradiated patients, post-operative patients, some pelvic procedures have already been done, and then you are going to attempt this colonoscopy. It's a big challenge. Sometimes I do it early in the morning. I just lose it. अरे आज नहीं अभी छोड़ दो शाम को करेंगे. Or possibly I do it in night. At the same juncture, sometimes you are frustrated. You are really literally frustrated. I have seen Dr. John Bagley from UK, when I was there for 1 month. He used to say it is the most frustrating procedures for a learned endoscopist also. Sometimes it is very frustrating. And the biggest danger is if you do manipulate very hardly, you may perforate the colon, and eventually everybody knows what happens. So it is
But
really
perforation from the hands of the surgeon is very, very least possible. From a gastroenterologist, it can happen, medical but unless and until you are very harsh and you are pushing it blindly, then only a surgeon can cause a perforation.
It's really challenging
because we
to
are
learn it.
actually a gentle people.
Then don't do colonoscopy. Let them do the colonoscopy, you will get perforations.
So
you are
treat-
charging 5,000
So
for perforation,
instead of-
you can charge 1 lakh.
So treat the complications, huh? Don't. That is
Just
good
joking.
message.
Thank you.
Thank you.
Very nice
Thank you so
presentation.
Even for this you get a coupler. You can get a coupler. With this.
madam. Madam, you go to OT, will moderate, sir, will moderate. Will moderate. तुम्ही कुठे चालला मॅडम? या नाही तुम्ही जाता का कुठे? काय शी वॉन्ट्स टू गो केतकर मॅडम. अच्छा तुम्ही जाताय आता तुम्ही निघता आता डायरेक्ट.
काय म्हणतात सासरे बुवा, काय म्हणतात?
काय सासरे बुवाच्या हात. सासरे बुवा झाला बसून कालचा एवढा चांगला इव्हेंट. कालचा बर्थडे मी हरवला. हॅव नॉट डेअर. काय झालं आता? काय झालं नाही मी पहिल्या दिवसापासून आलो. झालं काय, काल मी दिवसभर आम्ही सगळं काम केलं टुगेदर, ऑपरेट वगैरे सगळं केलं आणि रात्रीला मग मीच डिक्लेअर, मलाच माहीत झालं ते गुपी त्यांचं की आज यांचा बर्थडे आहे म्हणून. त्याचं थ्रू अँड थ्रू आलं असं मॅडमकडनं. तर मग माझे जावई आणि मुलगी नाशिकला राहतात. तर नाशिकहून ते मला भेटायला येणार. आम्ही 9 पासून वाट पाहतो. 9, 10 ते 10:30. आता 10:30 आल्यानंतर मुलगी 2-3 महिन्यापासून ती कधी आलीच नाही घरी. आता तिथे माझा मुलगा आहे. सो आम्ही रात्री 1:30 वाजता.
हॅलो, हा सर.
मॅडम तुम्ही ओटीत जा प्लीज.
हॅलो
मॅडम सर ओटी.
हॅलो.
हाँ यस ऑडियो येते तुला?
हाँ तो ठीक है बैठे.
हाँ बोल रहे
सर. अरे
हॅलो, ओटी.
हॅलो.
हॅलो, हा सर.
बाकीचे माईक बंद कर सगळे. ओके व्हिडिओ आला तुला?
हा सर, व्हिडिओ आला तुमचा.
तुमचंही आलं. ऑडिओ क्लिअर आहे दोन्ही?
हा सर, ऑडिओ क्लिअर आहे.
ओके देन मी ऑडिओ म्यूट करून ठेव सगळे आमचे. आमचं ऑन ठेवून दे.
येस येस.
हां एक टेस्ट करून घे ओटीमधलं.
हो ठीक.
एक मिनिट. हां तुझा स्ट्रीमिंगचा ऑडिओ म्यूट करा सांग.
हा सर, हा कर.
3 नंबरचा ऑडिओ हे कर 18 मिनिट. हॅलो. सुशांत.
Hello, hello, sir.
Over there.
Okay. Sir, this is a 45-year gentleman
Huh?
with grade 3 to 4 bleeding hemorrhoids since last 1 year.
Anjali, she's
Hello.
doing.
Hello.
Yes, getting.
Ha. He has bleeding hemorrhoids with grade 3 to 4 hemorrhoids on examination. So I will be performing test procedure on these patients, sir.
Okay.
Okay. Now with gentle manipulation, reduction, manipulation of hemorrhoids, congestion reduce, with
Oh,
the proper lubrication.
Yes.
The tube-test proctoscope inserted inside. The light source is attached with, and now the first suture line, that is 4 centimeter above the dentate line, I am starting.
Yes.
Okay.
किसकी?
As the master innovator is with us, he can guide us with every suture passer, with every needle passage. You can comment, sir, that first is whether you will advocate a full thickness needle insertion or mucosa and submucosa, sir. Ladukar, sir. Hello.
Yes, yes, yes. We are with you, madam. We are observing you.
Okay.
हाँ.
Sir, I want a comment from you whether you will do a full thickness repair or just mucosa and submucosa.
No, no. In this procedure, we are mucosa, submucosa. They are to be sutured with whether part of the muscularis is also taken. It is described in this.
Okay.
No, but not thicker.
Okay.
It should be now your make the knot tight, madam. It is
Yes,
not.
yes.
It is not tight.
Yes. I will be holding it tight. Before I take the next needle passage, I will be tightening it, sir.
Make it
Then only-
doubly knot.
Yes.
Your head is coming.
Okay.
Just be on the left side or right side, whatever
Okay.
is. Yes. Ani, you have to take 2 throws, not single. It should be doubly knotted, no? So it will not.
Okay.
It will not be loosened then.
Okay.
Again, cameraman.
This is one, sir.
Again second one.
This is second.
Yes. Now it is okay.
Okay, sir.
And with the help of the needle holder, you can tight it.
Okay.
Yes. Yes. One throw, and second again from the same loop. Yes. Again she has applied on the second one. Okay.
Kara.
Yes. Madam. Get doubly lock one.
Yes.
Again it has to go through. Yes. Now it is doubly locked, and make it tight with the help of the
it
needle
is
holder.
quite tight, sir.
Make it tight with the help of the needle holder. Needle holder will be used to tighten it and to press the
Yes.
hemorrhoidal mass.
Sir, do you inject post-operative methylene blue in these patients?
No, madam. I never tried. Never tried.
Okay. I am regularly doing that. That has a fantastic results.
For what? For what you are adding?
Post-operative pain, sir.
Post-operative pain relief by methylene blue.
Yes, sir.
Hello.
Hello, Anjali.
Yes.
Yeah. Why do you use methylene blue, and where do you use? Where do you inject the methylene blue?
Sir, methylene blue is used for the post-operative analgesia. That is one. for any clean surgery. May it be stapler, may it be open hemorrhoid, may it be Chiute's procedure, may it be non-infectious procedure. It should be given in the fashion of the perianal block. Now, what is perianal block? The perianal block is the block which is giving all around the circumference of the anus. Now, what is the percentage of the methylene blue and the sensorcan which is used? The percentage is 1:4. Now, how to autoclave the how to make the methylene blue sterile? So what we have done at our hospital is, whichever the our ampoules or the large glass bottles they come, we have autoclaved those bulbs. That is one. Second thing is, per drum or per case we put that methylene blue, and it will go for the autoclaving. So that reduces whether the methylene blue sensitive sterilization aspect. That is one. So that if some worse thing happens in the due course of time, because whichever the methylene blue ampoules come, it is not written over that this is sterile. It is not written over it. And we get 10 ml ampoules.
Yes.
In market.
Yes.
So what we do is, we can take 1 ml of methylene blue and 4 cc of sensorcan. Okay, and that dilution we can fill in the bottle, glass bottle, and we keep it in the make it a seal bottle, so that it should not fall within your drum, and after the procedure you inject. Now how to inject? Total 4 cc volume in each of the ischiorectal fossa. Okay, right and left.
वारंवार सांगतोय.
Hello.
Hello, Anjali.
Ha.
You are taking only single throw, and that will not tighten the knot properly. It will become loose.
Sir, before piercing this needle, I am making it quite tight. So although it appears, but while I am passing the next throw, I am tightening it, sir.
No. Okay. Next. But Anjali.
Yes.
Why do you need to give post-operative analgesic solution, something like this, in Chiute procedure? Because it is essentially a painless procedure.
But okay.
Nobody uses it, and post-op analgesia, unless you are very close to dentate line, or little bit of discomfort, that can be taken care of by oral 1 or 2 doses of analgesics.
Okay, but sir, in my
you are happy?
No, not I am happy, but there are certain times we give. We do perform a hybrid procedures, like we excise sentinel tags, sir, if they are large. Suppose we do some large sentinel tags after excision, they give lot of pain, sir. So in that case it really helps, sir.
Okay, any question from audience regarding 1 minute?
Hello.
Yes, sir.
I am Dr. Rajpal. Yeah, sometimes we notice post-operatively bunch of threads inside, very loose threads inside. What is the reason for that, and what can we do for that?
That is one thing is, if you have not taken an adequate length of the suture, that is one. If you have taken 2 vicryl sutures of not much of the long length, and you have taken a tie in between for completing the circle, so that knot can get loose. That is one possibility. Second possibility is, at certain depth the suture may give away, or disintegration of the vicryl can happen, and that sometimes can give rise to the pieces of vicryl they are coming, and that is why I think Ladukar sir has repeatedly telling me that you need to have the two throws so that vascularity as well as the repair can be done well. But it happens, sir. This is a good observation that the pieces of the vicryl they are shelled in the seeds bath.
Dr. Anjali,
Yes, sir.
yeah, you're not taking double interlocking sutures. So, do you think that it may
No,
cause some?
I am taking. Sir. This is one. See,
Okay.
written.
Okay.
And
Madam, head little on the left side, please. We are not able to see. Cameraman, we are not able to see.
कैमरामैन अच्छे से बताओ.
Have you ever noticed some sort of stenosis or this thing narrowing of the lumen during this procedure, after this procedure?
No post-operative stenosis noticed. Only thing is a sense of tightening like situation patient feels.
Okay.
This is one and you need to take a second. Okay, brother? So, ये उनका कहना है कि ये लूज होते जा रहा है, डबल लेना है.
How many days do you give the antibiotic, and which antibiotic do you give?
Antibiotics are 1 day injectable and 4 days oral tablets. Cefixime.
And only cefixime?
On the first the patient till patient is hospitalized, we give the injection zone and amikacin.
You don't give metrogel?
No.
You don't give metrogel?
No.
What the house has to say regarding the use of metrogel in anorectal cases?
Hello.
Ha.
Anjali.
Sir, unless and until patient has some necrotizing infections associated, then only we prefer to give metrogel, sir. That is we have made a protocol in our hospital. चला ठीक है पकड़ इकडूनच आहे इधर से आने का है how many days you give sir Ladukar sir Sir, this completes my first row.
Yes.
First circle, okay. Great.
First circle.
Yeah. Nice.
Single घेतलेस बघतो पुन्हा. That is why it is not tightening. that it has become loose. Huh?
इसको थोड़ा सा सिट डाउन करना पड़ेगा रे.
डन. अच्छा अच्छा ओके. इसको रिकॉर्ड किया क्या? नहीं हाँ. अच्छा अच्छा ओके. जैसा मर्जी अभी कर लो. हाँ थैंक्स पहले तो सर्टिंग होने के लिए.
कट
क्योंकि क्या है कि
सीजर
इट्स
रहने दो ये, बाद में कट करेंगे इसको. ओके 1 more वाइग्रेल. हाँ 90च लागते. हळू हळू. अभी अपने को नीचे नहीं. ठीक है. हो सेकंड लेयर आई एम स्टार्टिंग विथ सर. एक और उनका कहना है कि और एक सुचर इसमें से लेने का है.
ब्रदर आपका नाम क्या है? आपका नाम क्या है? ओके, कल कितने हुए केसेस? कल कितना हुआ केसेस? 7। क्या क्या हुआ? किसने किया?
Hello.
Yes.
Anjali, can you hear me?
Yes, yes.
Anjali, you are not pushing the knot tightly.
Okay.
We can see the oozing over there. Either
Sir.
you have to use
Sir,
needle holder
this is-
or you have to use that gulel like knot pusher.
Sir, it is what is my routine practice is before I take the next suture passer.
Okay,
Next
okay.
thread. See, now it's
Yes,
extremely
yes.
tight.
Yes.
So why to apply the force unnecessarily? 1 or 2 passage I can tighten it, sir. No problem.
But the fact is ki when you are tweaking double interlock,
Huh.
once you push it nicely,
Huh.
that will snug and fit over there tightly.
Okay.
Yeah.
So you feel as if it is not getting snugly?
Yeah, it's looking like a bit looser. Yeah.
Okay, okay. I will take
The
care.
sentiment of the house is that it's looking bit loose.
Okay. Brother, it is extremely tight. Tight नहीं है? पकड़ो इसे, यहाँ से नीचे से हाथ डालो. हाँ. Sir, what is the maximum length of the vicryl you require? This 95 will suffice for one row. लाडूकर सर.
बोल जरा मोठ्याने बोल अंजली.
हाँ सर. मी म्हटलं की मॅक्झिमम व्हायक्रिलची लेंथ किती लागते ॲव्हरेज सर्जनला?
काय
व्हायक्रिल लेंथ जी आहे समजा आपलं जे येतं की 95 90 एक 45चं येतं एक 90चं येतं.
अराउंड 3 weeks 3 months.
Hello, Dr. Anjali.
Yes, yes, sir.
Yeah, how many days you want to give the laxative to the patient in the post-op period?
Laxative?
Laxative. Yeah.
Around 3 to 4 weeks, sir.
Okay, and in the
3 to 4 weeks.
Okay, fine. And in the
Since the day of operation.
after the operation, okay, fine. And after the operation, any surgery causes some injury, you know, right? So any injury will cause some edema also. So what I think is not tightening the
Any-
sutures.
Anyone
we
from
could not hear
audience
you
have
clearly.
any questions?
Hello,
Sir, we could not hear you clearly. Your voice is very feeble.
hello. Now
Ha.
can you hear me? Hello.
Ha ha.
See, what I was saying is, it's basically a comment. I'm not asking you anything because someone from the house was saying to tighten the sutures with the needle holder. But what I believe is because any surgery is an injury, so after the injury there is going to be some edema.
Ha.
So that edema itself is going to tighten the sutures. So you have to tighten the suture, but too much tightening I don't think is required because as such edema is going to.
Actually, that is my hand practice or habitat of hand. So many.
And in the initial period, do you think there is a more requirement of laxative than maybe after say a week or so?
No.
It is the same.
Throughout the same.
Okay. And which laxative you prefer?
The lactitol.
Acha, okay. Hello.
Yes.
Any role of sitz bath in this kind of surgery when where there is no external wound?
Yes, definitely. It is going to have a soothing effect in any
Hello,
perineal
Jatin.
region surgery for that matter.
Hello, Jitin, can you hear me?
Yes, I can hear you, sir.
जितिन इसके बाद भी एक और हेमोरेड्स का है क्या?
इसके बाद में है ना सर?
Jitin, is there any case, next case of hemorrhoid is there?
Yes, it is there, sir. Next case, in fact, in the next case, we are doing a pre-op rectal ultrasound. Hello, can you hear me?
Hello, Dr. Jitin.
Can you hear me, doctor?
Yes, we can hear you.
Yes.
Dr. Ashutosh Kharche is here
Yes.
for that case.
Okay. Kindly send him up. So what we intend to do is, basically, we want to show the vascularity pattern before the Dr. Chifte's procedure and after the procedure.
Yes.
We'll be using both the modalities, that is rectal ultrasound.
Okay.
And also the ICG, indocyanine dye. We have already given indocyanine dye to one of the patients. So you send Dr. Kharche to the OT,
I'll send
please.
him in 10 minutes.
Yes,
Okay.
kindly send him.
Ladukar sir, here I am completing the second row of suture. I am taking the knot. This is the last knot. Patient has no external tags here.
Now if they are showing, scope should be inside.
Anjali?
Huh? Yes, Shanti?
Now anything you want to show with ICG? Devascularization?
Anything?
ICG.
ICG?
Ah.
Okay. I do not know. This patient is for
Japanese-
ICG DI, madam.
If they want to give and show it, then we'll wait, or otherwise okay.
Okay.
Any plan
ICG?
for the next case?
No. No, not in this case, Shanti. इसको pack.
Okay, Anjali.
Yeah.
Thank you. Nice
Thank you so much.
demonstration.
Thank you. In the next case, I think someone will demonstrate. Anal pack.
Ultrasound about the dilated vessels along the submucosal lining, the plexus which is formed, and the feeder arterioles as well as the veins. So we can appreciate the diameters of the vessel, the velocity, which are seen pre-procedural, and its success after the procedure, that how the dilated vessels have reduced in size and whether the procedure is successful in a particular patient. Thank you. We'll be shortly following with the videos.
Yeah, he's on.
Hello. Dr. Rahul Fofle is a very nice and very good radiologist which we have today. He'll be showing live this thing, the rectal arteries.
So this is nothing but
I'll just come to you.
Hello, so coming for the live video demonstration of the sonographic endorectal ultrasound. This is nothing but the probe within the rectum. On the screen we can see the mucosa, submucosa layers as well as up to the serosal layer. And when we go for the Doppler flow, we can see multiple dilated blood vessels which are protruding up to the mucosal surface. And these are nothing but the hemorrhoids.
आपण जेव्हा सिलेक्टिव्ह घेणार आहे ना तेव्हा लागते आपण सर्क्युलरच घेणार आहे ना.
We have taken the velocities and it shows high velocity.
Hello. Hello, in the OT.
Yes.
Hello. You are showing preoperative, no?
Yeah, it's a preoperative live demonstration of the vascularity.
Sure.
Yes.
No, you can talk.
Yes.
Can you see?
Rahul.
At which positions you are showing it? 3, 7, 11 or
6 o'clock position. No, it is
Please
9 o'clock.
Yeah, he is focusing all around, but he is seeing all around, but he'll focus on 3, 7, 11.
Can you save these images?
Yes, we can.
Because we have to, after doing the surgery, when you will be doing it again, you can compare the things.
Yes, no, of course we'll be saving.
Yes.
मी अगोदर 3 o'clock ला पोझिशन घेतो. तू 6 ला घेते का? 6 ला घेतो.
So we can see the dilated vessels at 6 o'clock position, 6 to 7 o'clock position, and these ones are at 3 o'clock position. The images have been stored just 2 minutes prior to the...
Sir, please talk loudly. We are not able to hear you.
Sir, we can see the images. And these are the blood flow. The blood vessels are seen at 6 o'clock position.
Your face is coming in between.
I am so sorry.
Yes. Now, yes. Now it's okay. Now, please describe.
So this is the transrectal ultrasound, and we can see the dilated blood vessels at 6 o'clock position.
Yes.
And this is at 3 o'clock position. The blue and the red vessels which are sparkling at the background.
Yes.
And we have recorded the velocities
Speculum
from these areas. These are the vessels which are protruding through the submucosal layer into the rectum lumen. So these are nothing but the hemorrhoids, the plexus which has formed. Now the pre-procedure scan is done. We will be moving towards the procedure, and following that we will be seeing the post-procedure scan.
Okay.
माइक लाओ इसको लगा दो.
लाडूकर सर.
Very well done. Now,
लाडूकर सर.
Speculum.
who is to operate now? Who will operate?
Godrej sir and me will be operating.
Achha,
I
okay,
will be
okay,
assisting
okay,
Godrej
okay,
sir.
okay.
Now, could you see this, sir? You able to see this?
Yes.
Okay. So this is a endoluminal transrectal probe, sir, which was just now used by the radiologist. See, this is the one. The transducer has this grey color line, which you can see. This should be in contact with the mucosa where you are demonstrating with. If there is a gap in between the mucosa and this transducer, you will not able to see anything. That is one.
Yes.
So this transrectal ultrasound has certain implications, that whenever you are measuring at what distance, how much is inside the lumen, how should be it should be hold, what is frequency of this probe. Now frequency must be between 3 to 10.
Yes.
5 to 15. So it has a varied frequency, and this gray scale should be in contact with the mucosa.
Yes.
Fourth thing is, once you assess the color Doppler mode, the color Doppler mode will give red and blue zone. Red and blue zone indicates that there is a dynamic flow of the blood to and fro.
Yes,
If that flow, if you ask the patient to cough or do some strenuous exercises, it will again show the increase in the graph. Second thing to demonstrate is the velocity demonstration, like we do in the color Doppler or the vascular thrombosis, we want to demonstrate with. So this pulse Doppler or the color Doppler mode, this has a different flow in the arteries and the veins and the arteriovenous malformation. So arteries, they have a uniform up and down flow, while that of the vein, they have a triple line graph. So these basic skills we have to know, although we are surgeon. Everywhere radiologists cannot have, it is a luxury for Jiten, but we cannot have this luxury.
Yes. We
like
cannot,
it.
in individual setup it is not possible.
External picture.
Only we have to show that before surgery how were the vascular, how was the vascularity, and after doing the procedure how it is the if the vascularity is reduced or not, that we have to show.
Yes,
See,
now
on
it has
ultrasound
been
only.
pre-recorded, sir, on
Thank
the
you,
screen.
thank you.
The
Let us-
pre-operative flow has been demonstrated.
Yes.
Now we are performing the surgery. Now
Yes.
post-surgery also, he will be demonstrating, sir.
Yes. Go on. Proceed with this.
Okay.
You can finish the procedure now very fast now. We will see only, we will be back to you, we will be watching your surgery, but we will be talking to you when we will be doing the ultrasonography post-operatively.
Okay.
Immediately.
Okay.
Yes,
Okay.
start immediately now.
Yes,
Okay,
yes.
please.
This is
We are
external
watching
view.
you.
Yes.
This
So,
is
you are able to see the screen picture, sir?
external view.
External hemorrhoids, and you could see this, sir?
प्रोडाक्ट फाइल्स चालू आहे का नाही त्यांना कानाला लाव ना हां आहे ना जेली दे
Dr. Anjali, it is very well.
Yes. Sir, Ladukar sir. आधी मध्ये जेली ना.
मध्ये पण लावलं
Hello.
Hello.
Yes, madam. Proceed.
Yes.
We are
Yes.
seeing.
Okay. Now Ghatole sir is inserting the proctoscope
Yeah.
inside.
गॉच पीस घे का आर्टिफिशियल घे हां बस तू क्लीन कर तू बस की नाही बस बसल्याशी होत नाही ते द फर्स्ट स्टिच ह्याला जेली लाव ह्याला पण
Madam, camera can see proper inside the properly. We see the one side.
आतमध्ये go inside.
फर्स्ट
Yeah, because of scope. Yeah, that is scope trauma.
अरे आर्टिफिशियल ते काय नाही दिन
Anjali, ask the anesthetist to give a little more head low, please.
Yes, yes.
Little more head low will help you in visualizing this. The cameraman will be able to show it better.
Yeah. It's quite
special
bleeding there because of, I think, trauma.
बिल्डिंग इथं आहे खाली
Not much blood, but it's because I'm magnified at least 20 times. That is why it is looking much.
ते मी धरल्याचं खाली आहे बघ इथं कोणतरी हां हे रोटेट होते ना स्टँड कसं करणार हां हे बघ थोडं पुढे घे हां त्याचं धर थोडं हां करेक्ट तू वरती हां वरती ओढली ना होते मग हा वरची थोडं फिरव रे हां सगळं सांगावं लागतं ते आपले असिस्टंट आहेत ना फिरवतात पटकन हां फिरव रे पुढं फिरव थोडं क्लीन कर नाही मोठं आहे हां हां बस
आता सर एक क्यूटे प्रोसिजर
थोडं फिर अजून थोडं हां त्याला फिशर असल्यामुळे थोडं ब्लीड करा फिरव रे फिरव अजून हां हां बॉम्बे मॅडम एक गॉसपीस घे का
हॅलो अंजली
हां मॅडम बोला थोडं फिरव रे
हॅलो
यस कानेकर सर हॅलो
हॅलो कॅन यू हिअर मी
हॅलो
हॅलो
यस यू आर ऑडिबल सर
yes yes no I am wondering whether this suture is very close to the dentate line.
Yes,
it is. So the one you are going to take is further proximal. Next row will be beyond this.
अरे आता तटू देऊ नको रे काढते हां हां
हाँ तो छोटी है तो नवीन है त्याला 2-4 सेंटीमीटरची आहे हां 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 हॅलो अंजली
हाँ, yes, sir.
are you using this older model where there is.
Sir, bit louder.
Are you using the older model of this scope?
Yes.
Where the flange is very small?
Yeah.
Because that piles mass, this external hemorrhoid is getting, and it this is.
Godrej sir, older आहे का हे older proctoscope आहे
Older
का?
proctoscope आहे.
हा?
Older आहे. गती दे. थोडं घे. हात काढ रे ते. सगळेच येतात.
फर्स्ट लेयर हो जाएगा ना?
हाँ.
थर्ड क्वार्टर से
हाँ.
बता देना.
हाँ.
जो वहाँ पे 10 मिनट में वो दिखाना है लेजर.
ये फर्स्ट लेयर ही चल रहा है.
फर्स्ट लेयर होने के बाद.
फर्स्ट लेयर होने के बाद
बता देना 2 मिनट के लिए चेक द माइक ऑडियो देयर.
अंजली इथं निडल स्टक झाला बघ कुठं तरी. आय. हे फार वाईट होतं एकदा स्टक झालं ना. हां. फार
आज जात नाही लाईट नीट कर ना तो एका बाजूला झाले ना सेंटरला कर.
नाही तर काय
आज ओव्हर आहे सेंटरला करतो.
हे पानले आहे ना सर त्याच्या
नाही तो हलू शकतो थोडं.
नाही असं कर.
वर घेऊ.
चला पुढे टाईट बांधले.
वाटपीस दे का.
हां
करेक्ट.
आता बरोबर.
मी इकडे पिक्चरमध्ये बघतो.
झालं. पहिला स्टिच कुठे आहे इथं. हां सर. हां 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 ते प्रोक्टोस्कोप घालताना.
सांगितलं तुला
इधर इधर अंजलि इधर. हां हां सोड. आता आपण ते दाखवायचं बंद करू. झालं की झालं. ते आता कुठे बघायला पाहिजे पहिलं. लांब ठेवलं ते ह्याच्यामुळं मागं गेलं ना. आता हे आपण थांबू आता इथंच. ह्याला मी काय करतो, ह्याला सुचर घेतो. काय इथे सापडत नाही, ह्याला सुचर घेऊन बंद करतो. हे चेंज करतो. हे बघ. सक्शन देतो कर थोडा. हे बंद करते.
केस और कर म्हणजे कलर दे. ऑडिओ बंद कर.
हां
आणि तिथे असं लिटरली असा हम्प येतो. तो हम्प यू कॅन गो फ्रॉम धिस टू धिस. People are starting from 12 o'clock also. तुम्ही सुरुवातीला टाय घेता आणि एंडला टाय घेता. 6 o'clockला असेल तर इट इज नॅचरल वॉट टाईम यू आर डुईंग इन ओपन सर्जरी यू आर डुईंग डे अँड नाईट. इट इज व्हेरी अशी टाय घेणं किंवा अशी टाय घेणं खालच्या बाजूला असेल तर इट इज नाही 6 o'clock. हो आता सर गेले माहिती ही दुसरी चालू केली. फ्री ऑफ हे दाखवलं ना आता सोनोग्राफीमध्ये घटोळेंनी दाखवलं. ओके ओके. देखो जरा फोन करो और बोलो. हेलो हेलो
डॉक्टर कनेकर.
हेलो.
हाँ कनेकर सर. कनेकर सर.
पिंगेस का.
हेलो. डॉक्टर कनेकर. Hello, anyone in the hall?
Can you hear us?
I can hear you very well.
Yes, and we can hear you very well.
That's great. So this patient is a 41 years old male. He is presented with painful defecation and bleeding per rectum. Clinical examination revealed a fissure in ano along with the grade 3 hemorrhoids. So what I plan to do is laser procedure for both the fissure and the hemorrhoids. You can see it is a grade 3 hemorrhoid, and we nowadays use our finger to feel the pulsations of the rectal artery, the feeding artery to the vessels.
Okay.
So we ligate just at the place. This is called as a finger hull or a finger probe.
Okay.
So we can feel the pulsation of the artery, and we take a double interlocking suture there to occlude the artery.
Okay.
Yeah, and after that we give the laser energy to this. Suture, please.
अच्छा, मग लेझर देणार का त्याला? ते हे
Yeah. जल्दी लगा के देना था ना यार.
हेलो.
इसको छोड़. Yes sir.
हाँ, the inside vision is not proper. Just
Yeah.
कैमरा टिल्ट हो गया है, नहीं तो सर्जन का हेड निकाल के बाजू में रखो थोड़ा देर.
हाँ, दिखाना तू. नहीं कैमरा टिल्ट हुआ, जरा दिखाना. सर,
we are not able to see it inside.
Raju,
are you operating at 3 o'clock?
Yes.
Okay.
This is a 3 o'clock pile mass.
Okay.
So what we do is first take a one bite and then with the give a traction with that and go just little above that.
Okay.
And take a second one.
Like figure of 8.
Yeah, like figure of 8 suture.
Okay.
Okay na? Yes. Yeah. बबन तू हाथ खड़ा होकर शक्ल देखने के लिए खड़ा है क्या? इसको निकाल दे अभी. हाँ.
Jitendra.
Yes sir.
Hello. You have a ultrasound there, no?
We have ultrasound there.
Did you show the pulsations of the vessel before ultrasound? Before
Sir, we what
the
we
finger only.
No. What we have shown is another patient. This finger, what we want to stress point that is actually not required. That we have used to document for the documentation purpose. It is going, and what we are showing is here is by the finger. Because everywhere and every time we cannot show that.
Okay.
With the ultrasound we cannot use it.
Correct.
This is a more practical and more because hemorrhoids are such a common disease. We have to do it day and night.
Okay.
Yeah.
Now, still for documentation, after taking the stitch, can you demonstrate it with ultrasound to show that your digital perception is fairly accurate and that you get the obstruction? That
yes, we can show that. We can show that.
Just try and see with your finger whether the pulsations have
stopped. I can feel that the pulsations are not there by finger now.
Now,
yes.
Just
so we'll document it with the ultrasound. आ जाएगा this thing ultrasound वाला है.
हाँ.
उसको डॉक्टर हॉल को बुलाओगे क्या? Yeah. Dr. Rahul. Dr. Rahul. Machine लेके आना पड़ेगा ना. So in the meantime that machine comes, I'll ligate all the pedicles.
Okay.
Okay. So now I am looking for the 7 o'clock. हाँ. नहीं. Yeah. So I can feel the pulsation at 7 o'clock here. Yeah. Okay. So lift it again and take a little. It is yeah. Cut please. $11 o'clock. Clean. थोड़ा सा और ऐसे yeah. So at 11 o'clock now we are approaching the 11 o'clock pile mass. उठा ले हाँ इतना जोर से नहीं हाँ little more head low please. तू छोड़ दे उसको. Yes. ऐसे ये एंगल ठीक है ना. एक आदमी पकड़ेगा झेलेगा. दो लोगों की जरूरत नहीं है. What we do is sometimes if the pile mass is bigger is milk the pile. उसको ऊपर से pressure देना. ऐसे इसको रखना. तू पहले रख. पाइल मास कहाँ पे है. हाँ इधर जस्ट तेरे नीचे. हाँ प्रेस कर दे. हाँ या छोड़ दे. Yeah, that's it. So we have ligated all the pedicles.
Hello,
Just remove this.
Jitendra.
Yes, sir.
Why not 2 stitches? Why only 1? Now
No,
we
no.
know
Uh-huh.
that the feeding vessel should be tied at 2 places so that the...
No, I think, sir, this thing, taking figure of 8. Suchana, we are not taking, in test procedure, we take a 1 throw only. We don't take the second bite. In the, here, what we are doing is taking a figure of 8 suture. So there are effectively 2 sutures only at that same place.
No, no, no. You are tying it, the feeding vessel only at 1 place. That is what I am asking. Probably they say that DG Hall, the problem is that you are tying the vessel only at 1 places. Barring other things that you are only tying the major feeding vessels, you don't tackle the secondary vessels. But in Chiute's procedure, what we said, that to avoid the collaterals developing, the feeding vessel should be tied at 2 places with a gap in between. So here also we can try that and see whether our results improve on that.
Yeah, that's a nice idea, sir. Basically, the proponents of this procedure have tied at 1 place. That is why I am doing that. But your idea is a good idea. What they propose is basically they tie at 1 place, and then when they give the laser energy, so that also basically blocks at the another level. So effectively it is at 2 places. One is by the suture and another is by the laser. But not taking another suture is
not a bad idea.
Not a bad idea, and it's going to be of some benefit only because you will be having little more fibrosis. So especially at this, this is a little bigger pile mass among all the 3 at 3 o'clock. This is the biggest pile mass among the 3. So here if we take an extra suture, it will be of some help.
Yes. Anyone from the audience? Any doubts, any questions, any clarifications? Anyone? No. Up. Okay.
Mop, please.
No, no, no. Up.
Mop. See, there is one another procedure called as a recto-anal repair. When there is a very lax mucosa, so in that we keep on taking sutures in multiple throws. That is sort of that forms a sort of a plication of the mucosa. So the hemorrhoid masses gets pulled up. So similarly, we can have according to the requirement how many sutures we can take. But as far as the idea of having 2 sutures is a good idea. नहीं हो गया अभी वो तो टाइल मास्क को जब करते हो गया तो इसके ऊपर ले रहे हैं. Dr. Rahul is here. We are lucky to have Dr. Rahul Pople with us. He is a radiologist with us. He will be showing us whether the stitch has taken care of the feeding artery to the hemorrhoid mass or not. And I like to introduce Dr. Vaishali Ahire also. Dr. Vaishali, kindly. Dr. Vaishali is a senior anesthetist at Godrej, and we are lucky to have it. She is highly competent and very efficient, and we are blessed to have her in this workshop also. Thank you, Dr. Vaishali. Yeah. Huh? Yeah, yes.
So here we are with the patient. I am showing you the pre-procedure images.
This is the post-procedure.
No, I am showing the pre-procedure images right now. Here we can see the redundant mucosa, and when we put the color Doppler mode, we can see the dilated blood vessels reaching up to the mucosa and into the lumen. And with the color velocity, we can see that it's showing high velocity arterial as well as the venous flow. So consistent with submucosal kind of small AV malformations or the plexuses, and we can record the velocities and the resistance index to show it's a low resistance index AV malformation submucosal. And here we also record the diameters of the vessels, showing giving us information about the size of the vessel prior to the procedure. And now immediately post procedure we are scanning the patient. As Dr. Anjali had spoken few minutes back about the probe and its length, we have to introduce the probe gently as we do it for the poor rectal examination, and the same 12, 9, 6 and 3 o'clock positions are marked. You can change it. So here we can see that post procedure, it's a live video, and on color Doppler, just adjusting the images, just a moment. The vascularity has tremendously reduced, only few blood vessels are seen, and the dilated plexuses which are protruding into the lumen are not well seen or absolutely not seen in the present scan. Sorry for that artifact. The images which prior showed multiple dilated vessels are possibly occluded, and we are not able to demonstrate them, thus confirming that the procedure was successful. Few peripheral pararectal blood vessels and internal iliac blood vessels are seen, just to show that comparison that Doppler modality is in the best of its signals. Thus the procedure seems to be complete. Thank you very much.
नहीं अभी लेजर रह गया ना, अब नहीं अभी तो हो गया, टाई करने से हो गया ना, टाई करके कहीं इफेक्ट आ गया दिखाना, फिंगर इज एज गुड एज रेक्टल. हाँ बराबर बाकी तो नहीं पड़ेगा. हाँ right. So thank you so much, Dr. Rahul. Dr. Rahul has shown that pre-procedure the vessels which were feeding the hemorrhoids are no more feeding the hemorrhoids now. That means that finger hall is as good as a rectal or digital hall, as good as a rectal ultrasound or a DGHL. So there is no need for an expensive gadget or finger if well trained.
Hello, Jitendra.
Dr. Kanekar, can you hear me?
Yes, yes, yes.
So if your finger, if you train your finger accordingly, it can very well feel the feeding vessel to the hemorrhoids.
Yes.
So, but you have to understand this procedure versus Dr. Chivte is a difference. Like this is this cannot take care of late grade 3 and late grade 4 hemorrhoids. It is basically meant for late grade 2 and early grade 3 kind of hemorrhoids. Yes. And since we are just looking at the feeding vessels, there are still chances of the hemorrhoids forming at the other places.
Now, are you going to combine this with laser?
Yes, yes, of course. Yeah, laser please. Mm-hmm. So now I'll be doing a this thing laser hemorrhoidoplasty for this patient. Can you see this?
Yes.
This is a conical fiber, and what we are using is a machine from the new laser. करना ढीला करो नीचे से ले लो नहीं तो Can someone show the settings? इसको छोड़ देना ले ले ठीक है So what we do, can someone show the settings first? ठीक है हाँ Yeah, we keep the wattage at 6 watts and give a pulse of 3 seconds. We are entering through the mucocutaneous junction. एक मिनट. Basically, giving a burst at the time of entry helps us to enter, and what we have to ensure is that we are not too superficial and not too deep. That we have to ascertain by switching of the light. Can someone give me the gears also? This eye protective gear. Yeah. ऊपर का लाइट बंद कर देना. Yeah. See. So, if it is like this, it is very superficial, and if it is not seen, then it is deep. So we have to maintain it somewhere here. I will please. Yeah. Yeah. So I'll start delivering the energy. Ready? And we have to keep rotating it. How many watts? Yeah. 70 joules. So we try to give, because this is a bigger mass, we'll try to give around 150 joules. Yeah. So it is 154 joules. And can someone on the light now? See. Yeah. Can you see?
No,
it has although it has shrunk, but it has not shrunk fully. Okay. But we should not be giving too much of energy.
Okay.
The idea is basically this thing. The process of the effect will come even later. This thing, the full effect, we should not try to achieve it on the table. Eyes, please.
Okay.
हाँ. पकड़ने से पकड़ ले उसके बाद. तो प्रोसेस शुरू करने से पहले मांगा था मैंने आई से यार. कोऑर्डिनेट करना चाहिए. हाँ. हाँ जल्दी दो. हाँ हो गया लेजर हो गया. So this is ice pack, ice candy made out of the glass finger.
Show us.
Yeah, this is the glass finger, and it is cut like this so that at the end we can tie it outside.
Okay.
But I like to give it after every burst of laser.
Okay.
Not only at the end. Yeah. हाँ गोगल्स निकाले 2 मिनट. Yeah. So we'll keep it for a minute. हाँ छोड़ दे. नहीं लेयर का एक हुआ है, अभी पूरा नहीं हुआ है. This is a sterile gloves pack. It comes under the gloves. We have got both types of gloves, sterile and non-sterile. And as such, how much sterility do you need in this area? Because we are not cutting anything, na? There is no raw wound here. Yeah. चलो देखो, क्लीन करो, इसको क्लीन करो. उधर देखना यार तुम. हाँ. चलो क्लीन कर. बहुत टाइम लगा था यार. हाँ. तो एक और रेडी करके रख लेना ऐसा. Yeah, nearby any person who is there, he should ideally be wearing the this thing eye protective gear. चलो इसको रखना. चलो लेजर फाइबर. See this pile mass. हाँ this छोड़ना तू. जब मैं ऐसे पकड़ता हूँ तो उसको छोड़ने का पड़ेगा. ऐसे कर.
Jitendra.
Yes sir.
One question.
Yes sir.
Can we use this ice finger?
Yes.
Prior to giving the laser pulses.
Yes, sir,
if it is done, will it help reduce the damage to the surrounding tissue, or will it reduce the efficacy of the laser?
No, sir. See, we can use it, but the thing is, even anyway, whenever there is a burn, you know, whenever burn of any kind, like it is a fire burn or it's a flame burn, any coolant effect of whether it is a water or ice has to be required only after that. There is no indication to give it before giving the burn.
Okay.
But the thing is, if you apply ice, it may shrink the pile mass little bit, and your energy can get concentrated on that. That way, it is can be of some help. But the idea of using ice pack is just to prevent the damage by the heat. Yeah. See. Entry through the mucocutaneous junction. Just before entry, we give a burst of laser. Yeah. We are entering inside, and here since the pile mass is not much, I will try to give just between 70 to 90 joules only. And keep on rotating the. It is now कितना हो गया 72. नहीं 154 था ना पहले. 154 plus 212 तो 70 joules I have given. I think that is good enough for this kind of pile mass. Ice pack kindly please. ऑटोमेटिकली तू मेरे को ये नेक्स्ट करूँगा तो ऑटोमेटिकली आई वेयर पहना देना मेरे को, है ना? हाँ, तू भी ध्यान रखना. Yes. Yeah. Clean. Yeah. ऐसे पकड़. Alice. हाँ, go. हाँ. Yeah. Now I'm dealing with the 11 o'clock pile mass. नहीं, इसको ठीक से पकड़ा नहीं है, छोड़ो.
Which is the next case?
So, entering through here by giving a, yeah. Reading is how much? 10 joules, no? Huh. Yeah, I will not try to come out. And at the exit point, there is some sort of bleeding is there from the entry point of the laser fiber. Yeah. I'll just give little more energy there also while coming out. Yeah, that's it. See? Clean कर. नहीं, एक मिनट. अभी इसको बेयर फाइबर मिलेगा क्या? बेयर फाइबर मिलेगा. आइस. इसको निकाल दे अभी. उसको निकाल दे. ठीक है. हाँ. So ice pack will not only reduce the lateral damage of the heat energy because of the laser, it also will help in the hemostasis. उधर उस वाले ओटी में क्या है? हाँ, अच्छा वही होगा. हाँ हाँ, वही वाला होगा. आईसीजी वाला होगा पेशेंट ना. लास्ट केस होगा शायद ना. नहीं, फिशर नहीं, पाइल्स ही होगा वो भी. हाँ, लास्ट केस. और इसका डॉक्टर राजपाल का केस नहीं हो रहा क्या? अच्छा, है ना. हाँ हाँ.
Okay, Jitendra.
Yes, sir.
Any more cases?
No, sir. We have another case of piles where we'll be showing again the Dr. Chivte's procedure, and we'll be showing the ICG with the help of the ICG what effect we achieve.
Okay.
That is the formation of the avascular zone.
Okay.
Yeah. On the Striker 1688 camera system.
Okay.
एक खुल गया है. एक और कैंडी लगेगी बेटा. हाँ. ठीक है ना. तेरा हो गया. हाँ हाँ, क्लीन कर. ये बियर फाइबर है. नहीं, लेकिन वो वैसा वाला नहीं, क्लाउड वाला नहीं. हाँ फाइबर के लिए, हाँ हाँ, नहीं पाइल्स के लिए नहीं, पाइल्स के लिए तो हो गया ना, पाइल्स हो गया, हाँ हाँ प्रेशर का है। अरे उधर ना ये कौन है यहाँ पे, अमोल या सुयश कौन है? हाँ वही तो, कुछ लेजर का ऐसा नहीं है ना? कि जैसे खत्म होगा तो मैं बात कर लेता हूँ, है ना? हाँ 10 मिनट, हाँ नहीं वैसे एक बार फिशर रेट में भी दिखाने का है। हाँ 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 यस सर, हाफ सर्कल, हाँ 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 10 वर्ड्स कंटिन्यूस, हाँ जली लगा, ठीक है ठीक है फाइन। Hello.
Yes.
Dr. Kanikar.
Yes.
See, in this same patient has got a fissure also.
Okay.
So I am just using the fiber again for the sphincterectomy.
Okay.
And in this, what we do is like for the hemorrhoids we use 6 watt energy. Here what we use is 10 watts, and it is on the continuous mode.
Okay.
So what we do is we feel with our finger the interdigital groove.
Okay.
And intersphincter. So above my finger is the internal sphincter.
Correct.
ठीक है ना? Just starting from the mucocutaneous junction. So it is like from here to here is the sphincter fibers. ठीक है ना? I am just protecting the external sphincter.
Okay.
So I'll enter from here.
Okay.
I'll go inside.
Okay.
And now I'll, with this only, by little tilt, I'll start coming out.
And it's a continuous.
It's a continuous mode. That's it.
Okay.
So this thing, but we have to again fill with the finger over this thing whether they have come or not.
Gap there.
Whether they have broken or not. So most of the times in one sitting they are not broken. So you have to sometimes go for the second time also. But what I am now doing is pressing here and trying to break the fibers.
Okay.
So after the laser energy they become weak.
Okay.
You know?
Manually breaking.
Manually you can break them.
Okay.
So it is a good procedure in the sense it's very minimal invasive, and you can see there is no bleeding at all.
Okay.
See?
But
still I am not convinced that they have broken well. I like to go again.
Okay.
Yeah.
And here you don't apply ice?
No, I'll apply ice.
Okay.
I mean, since the procedure is, I have applied ice after each this thing, but here since that is not yet complete. Yeah. They have given up now. I can feel them. They have the fibers. They have now. I could break them now.
Okay.
So that completes my procedure. I apply the ice right now. निकाल दो, छोड़ दो, निकाल दे. This is the ice which I am applying. वो जैसे पहले से बनाया था वैसा क्यों नहीं बनाया इसमें? हाँ तो उसको आपको टाई करना पड़ेगा. एक ठीक से ले लो ना, दूसरा ले लो, दूसरा ले, ये ले लो. Thank you, Nikunj, and what's your good name? Dheeraj and? Yeah, thanks Sandesh and Dheeraj from the NEO
Okay.
who have blended the machine.
For the benefit of audience here, what is roughly the cost of this machine?
This can cost you something between 8 to 9 lakh, but the thing it is negotiable. You can negotiate with these people standing behind me.
Okay.
I don't know they are going to give any concession because of the workshop or not. Yeah. Abhi idhar ek gauze piece rakhna. See, this is like what we do is like we put a gauze piece but in between, and now we tie it here so that it doesn't go inside and it doesn't go outside, and put a sticking outside. The ice, to keep the ice packet there, the place where it is required to be there, tie it like that and put a sticking. Okay? Thank you so much.
Thank you very much. Very good demonstration.
Thank you, sir.
Hello.
Hello, am I audible?
Yes, yes.
Yes. So now we are representing the pre-procedure Doppler for the Spiles patient. Hello?
Yes, yes.
Yeah.
We can hear you.
Yes,
And we
yes.
can see the picture also.
Yes. Hey, 11 o'clock.
Which position is this?
Sir, we are, yeah, this is the 11 o'clock position.
Okay.
हेच आहेत ना आपले. So these are the vascularity which is seen is the pile mass, and the initial diameter is 2 mm.
Okay.
Now we are demonstrating the velocity of the ये. Just a second. Artifacts येतात आहे. Yeah. So this is the pre-procedure 11 o'clock pile mass velocity.
अच्छा. बरोबर. ओके, ओके. हो, हो.
आता कुठे चाललो आपण? Okay. Yeah. Now we are at 7 o'clock position.
7. Okay.
For the 7 o'clock also we have the arterial as well as the venous waveforms. Oh. Am I audible?
Yes.
Yeah.
Yeah.
कनेकर डॉपलरचा साऊंड येतो का तुम्हाला?
हो, येतोय.
हां, गुड गुड. सांग त्यांना लोकांना.
अरे, डॉपलरच्या मशीनचा साऊंड का त्या वेव्हचा साऊंड नाही एवढा क्लिअर, जरा पुन्हा एकदा दाखवून दे सगळ्यांना.
ओके.
साऊंड नाही येत.
करा ना सर, करा.
ऐकार येतो का कनेकर?
हां, जरा पुन्हा एकदा.
हां, पुन्हा एकदा.
Listen carefully, everyone.
Can you see these waves and sound?
हो, हो.
Dr. Rahul? Hello?
Yes, yes.
Am I audible?
Yes, Dr. Anjali, you are audible.
Hello?
Yeah, you're audible.
So, how will you elicit that the previous and the post-operative flow, whether the intensity is low, frequency is low, what is your comment?
So this is the pre-op part.
Yes.
In the previous patient, we saw that the velocity was, I mean, there is complete obliteration of the blood flow.
Exactly.
After the procedure. That's
Yes.
what we are planning to look for.
Yes.
So right now we can see multiple dilated vessels. Because of the low velocity, we are not able to pick up the waveform so quickly in this particular case.
Okay.
I don't know whether the patient's blood pressure is also going to play some important role.
Yes.
Because
Position of the patient also plays a role.
yeah, because that will change our the way we are demonstrating it.
Yes. So, do you think with the parameters like the previously the distensibility of these arteriovenous cushions was 3 millimeter, for example, and post-operatively suppose it is 1 millimeter. Secondly, the spikes of the arterial graph, they were moving at the rate of 2 millimeter or 0.2 second per mm, and here it has totally obliterated, isn't it?
Yes,
on
that's
these
what
parameters we can say that there is a complete obliteration, or definitely pre-operatively and post-operatively there is a significant p-value.
Yet in the patient.
Okay. Okay.
So these are the arterial feeders which
Yeah.
are we getting.
Yeah, it's
this
a
is at
completely
3
flat
o'clock
line.
position.
Completely flat.
Yeah.
Yeah.
This is the and then the venous. This is the
Yes.
arterial feeder of the 3 o'clock position.
Yes.
And then the venous things we are the flow is little low or in this patient.
Yes.
So possibly that is the cause we are not picking up the expected waveform.
Okay. Now one thing you just demonstrate for the sake of the audience, you keep your probe over the radial artery or the carotid artery and let us see the
So this
how
is
the spike.
Yeah, this is the venous form. I can show it to the posterior tibial artery, which is
Please,
the closest.
please, so that it can be well demonstrated and everybody will get an idea that obliteration, minimal obliteration or no flow. Differentiation will be bit easier. Because of the lithotomy, I think there will be some fallacy.
No, we are getting some flow, but I would expect little more in a routine case.
Okay.
So this is the posterior tibial vessel.
Okay.
And we can see the
Yes.
blood which is throbbing inside it.
Yes.
Pulsating
Now,
inside
yes,
the
now
vessel.
show the pulse Doppler.
And on pulse Doppler, we will see the
Right. Right.
the arterial flow.
Yes.
I think so. The patient is also having some atherosclerotic disease, so it's not very typical.
Yes.
But yeah, we can see the high peaks in the Doppler.
Yes.
Similarly, we got in the artery at 3 o'clock and at 11 o'clock position in this patient.
Yes.
And the vessels were dilated like any small AV malformation.
Yes.
So we will now go for the procedure, and post procedure we'll observe, I suppose.
Okay.
Yeah. Thank you.
Okay. Thank you so much.
प्रिंट करके ले लो, ये भी है, हेमंत भी है।
Dr. Rahul.
Thank you, ma'am.
Rahul, one more question I would like to ask. That
Yes.
what is the angle of the transducer, or where you are going to assess the pulsatile wave? What angle do you keep? Usually 60.
Yeah, the ideally it should be 60 or around plus or minus 15, but when we are seeing through this transrectal probe, that angle doesn't come much into the picture.
Okay.
Though they say along the vessel across, but for practical purposes, even if we get the artery, we identify and see the artery and we take a waveform, that should be good enough.
Okay. Okay.
And we just have to follow the same parameters pre and post procedure so that there is no bias.
Okay. Okay. Thank you.
Yeah, thank you.
Thank you.
पाठीमागे ओढ रे हे ते हे स्टूल थोडं ओढ हां
हॅलो.
अजून थोडं
सर
बस ठीक आहे
सर हॅलो
हॅलो
हां नाही आम्हाला पिक्चर वगैरे काही दिसत नव्हतं. ओके नाव दिसायला लागले पिक्चर दिसते.
कॅन यू सी
येस वी कॅन सी द
मला मी ऐकू येतो का तिकडे
हो येतोय क्लिअर.
अच्छा
हो
आता यू कॅन सी दिस you know pilot or spigot of the proctoscope.
Okay.
Okay. We are going to direct this thing with this. Okay. Fine. Can you see it?
Yes.
And this will massage also. जे लोकांना मसाज करायला काय करायचं चाललेलं असतं ना this will massage. So piles mass will be reduced with this dilatation and massage. Okay. Have you seen change in that?
Yes.
Kanekar.
Yes, yes sir. We are.
Do you appreciate?
Yes, we.
मगाशी होतं त्यापेक्षा रिड्यूस झालेला आहे.
करेक्ट.
ओके.
येस.
मला प्रोक्टोस्कोप नहीं ते नको रे. यू डोंट वेस्ट योर एनीथिंग. मेरे को इसका स्कोप दो ना. हाँ ये ले लगा. ऑलरेडी आई हैव गिवन हेड लो. ऑलरेडी आई आउट डालो. जेली आउट डालो. बस ठीक है.
हो.
Now, proctoscope everybody knows now by this time, but just I will introduce you. This proctoscope has got one window. This is 5 centimeter or 3.5, and this distance is 4 centimeter.
Yes.
And brim is there.
Yes.
Importance of each is very different. Window is meant for operation. This portion is meant for compressing anal canal plus pile mass.
Yes.
So both will compress, and this portion, if you keep up to brim, that will keep in a position those pile masses. Okay. Here handle is there and snippers are there, where light rod can be fixed in that and it will not move much. Light rod, light rod there. Light candle there. And this light rod, you can see it. It has got particular angle, and this should not come in your view. Angle should remain here, you know.
Yes.
Once this angle is there, stuck down to the wall, okay?
Yes.
And this light will go at this window. That is the speciality has been done already.
Correct.
And you need not to keep this in between because it will come with every thread inside, okay?
Yes.
Any doubt about the proctoscope?
No.
Okay. So we'll put proctoscope inside and we'll try to check it. Right?
Yes.
This is proctoscope is in. We'll remove the spigot. Are you seeing inside?
नाही नीट नाही दिसत आहे सर.
Are you seeing inside?
नाही दाखवा नीट दाखवायला सांगा.
अरे काय आलं अडकत नाही ना. Are you seeing inside?
Yes.
This portion?
Yes.
Dentate line is here at the end of proctoscope.
Yes.
Are you seeing this rectal mucosa?
Yes.
And internal muscle protruding inside?
Yes. Correct.
If this protrudes, your job is easy.
Correct.
Because here rectum has been vertically divided in two portions. One from the internal sphincter onwards, it comes inside. External sphincter remains outside. So your job is easy. You can take suture line very easily. So this is the dentate line. You can go ahead from here. I put now light source in that. Okay, on केलं? On केलं का? Okay, can you switch off this light? वरची बंद करून टाका. कसं दिसतं बघा तुम्हाला.
Yes,
now,
very clear.
So after switching off this light will be clear, not because of very good light in this rod, but camera will not pick up this light unless this light is switch off. Okay?
Yes.
Now, happy? हे धरून ठेव कोणीतरी. Give me 20 a traumatic needle. Now for a minute you can put this light on. I'll show them needle how it is. हा light on कर. See, particularly हे मला दाखवायचं आहे बाबा. This needle, you know, it is 30 mm needle, half circle, round body. This thread, 20 vicryl, 90 centimeter long. Now this needle has got narrow tip, you know, it is not broad tip. You don't hold needle at the tip. So usually in depth when you are working, this needle wobbles. That's why you should hold needle little in. Did you get my point?
Yes, this is important things,
Yeah.
minor steps that are
आत नहीं दबो,
that
you,
will make
you
the
know you
things
press
proper.
here, because I am switching here. Did you get all this?
Yes.
Okay, I'll start it. So, आता इकडे third. All people they started at some different place. There is, you know, all are in democratic country, so they can start
You can
anywhere
do
they want.
anything you like.
Okay. So I am starting at 3 o'clock position, and first line will be 2 centimeter about the dentate line. See, now I am rotating needle. I am not pushing.
Yes.
Rotate.
Important point.
This is very important point. And once you hold this, we can ligate. कुठे गेलं?
Sir, is there any advantage of starting at 3 o'clock?
नहीं, असं कर. See, you can start anywhere, I told you earlier.
Okay.
Advantage depends on you, how you are practicing. Okay. Now this I am going to tie it here. And while tying, I will use vertical, you know. See, once you push it on, usually people try to put finger inside, but I will put needle over inside because a lot of space is in. So you need not to tie like this horizontally, tie vertically, okay? So this already knot has been put, this I will put it again. Did you see it?
Yes, sir.
Vertical ligation.
Okay.
I leave it like that, I may not cut it, okay? थोडं गॉसपीस दे मला. आणि हे असं धरतो. आता हा लाईट बंद करा म्हणजे आतलं त्यांना क्लिअर दिसेल. Is it clear to you?
Very clear.
Now once this thread is there, see, I am creating tent here. Tent is here, okay?
Yes.
Remember,
Yes,
this
sir.
tent is very important. Now we are going through that tent to put
Second.
needle, okay? So and now I am not leaving this. If I leave this tension, this needle will go inside. So better, see, turn it. No pulling or pushing. And now this V is in your hand. There right law puna. See, this loop is in my hand or V is there in hand. 1, 2. You don't leave this thread from your fingers. Just pull it. Okay? Fine?
Yes.
Again same tent. Create it. Needle should be hold in same strong position. Same tent can be created and go ahead with that. Okay?
Yes.
Once you brought it, I am just for showing purpose, this light I have put it. 1, this is second, you want you can have third or you can have on other side also, okay? So you can have regular knot too. Okay?
Yes.
Kanekar?
Yes, sir.
झोपला नाही ना कोणी?
नाही.
नाही जेवण झालं रे म्हणून म्हटलं.
Now see, there was mild oozing, and as he took the next stitch, that oozing has stopped.
See, that can
Yesterday
stop.
I was
beta.
telling you this slight oozing coming through needle puncture is quite common, and it should not bother you.
Again I am going to put same way, only 2.
Yes.
See, all this, if you are not happy, you can push it with this. No
to the-
way you require any forceps or anything. for this operation.
And the thread should be held by the surgeon only, not given to the assistant.
Okay? So I will switch off this light so you will see better inside.
Yes.
नाही माझ्याकडे पाहिजे याचं नाही याचं तोंड ऐकून घे माझ्याकडे करायचं कारण मी इकडे बाजूला बसलोय ना म्हणून हां हां सी थ्रेड छोटा आहे त्याला काही करू शकत नाही आपण कारण कॉमन थ्रेड आहे तो ते माहिती हां आता इनफ करतोय आपण मला आहे का नाही आय विल बी बेटर विथ 100 or 96 नाही ते हे वळतंय तुझं तू मला दाखव रे समोर नको पुष्कळ माझ्याकडे पुष्कळ कारण मी इकडे बाजूला बसलोय ना म्हणून बाकी काय नाही तू करतोस बरोबर करतोस पण मी इकडे बसलोय ना कॅमेरावाल्याला दिसलं पाहिजे ना म्हणून सगळे लोक इथे बसतात म्हणून डोकीसारखे आडवे येतात बरोबर आहे ना आणि तुम्हाला रेक्टल केस दाखवायचे असेल तर यू हॅव टू बी ऑन वन साईड ओनली तू माझ्याकडे कर राजा नाही हे धरलाच बरोबर आहे इकडे माझ्याकडे टर्न कर हे दिसतं का बरोबर
हो दिसतंय सर
and I am not bringing my head in between I feel
no and each time you can see that he puts the needle down and it is
रोटेट करतो थोडं कर कारण निडल थ्रेड खालती जाता कामा नये ओके
सर
हां
एकदा सुपरफिशियल स्टिच घेऊन दाखवा ना ती कशी दिसते म्हणजे नुसती म्युकोजातून जर स्टिच गेली तर ती कशी दिसेल ते जरा दाखवा ना
काय काय दाखवायचं
स्टिच एकदम सुपरफिशियल
अच्छा अच्छा सुपरफिशियल आहे ओके ओके मला आता आजकाल सवय गेली ती नाहीतर मी घालायचं नाही मी त्यात सी दाखवते ना एक तर हे लूज सोडलात ना मग तुमची स्टिच कशी जाऊ शकते हे बघ वाकडी बघितलास ना नीडल लगेच ती बेंड व्हायला लागते तुम्ही जरी नीडल चांगली धरलेली असली तरी सुपरफिशियल गेलात हे बघ हे सुपरफिशियल आपण गेलो ना ही नीडल अशी पडायला लागते लक्षात आलं का नाही हां सो दॅट वी डोंट वॉन्ट गॉज घे असं
आणि आता सर
दिस इज म्युकोजा सब म्युकोजा अप टू दी इंटरनल स्फिंक्टर not through the internal sphincter but part of it we will take because we are fixing the spinal masses to the internal sphincter we are not going beyond it because again infection can spread to intersphincteric space
एकदम ब्लड झालंय सर विजन सर विजन ब्लड झालंय कॅमेरावर फॉग आलाय की काय असं वाटतंय
काय झालंय
एकदम ब्लड झालंय विजन हां हां फोकस आउट ऑफ फोकस गेलंय किंवा लेन्सवर काहीतरी आलंय
आता बरं आहे का
नाही फोकसिंग प्रॉपर नाही आहे सर हां आता इज इम्प्रूव्हिंग येस बरं सर आता हा 9 o'clock to 3 o'clock ती जरा निडल होल्डर कसा धरायचा रिस्ट कशी टर्न करायची
ऍक्च्युली हे बघ आपण वी हॅव कम ॲट द 9 o'clock
येस
but once you have created this tent there is no problem at 9 o'clock also or 12 o'clock also you don't keep this loop easily. Loop should be kept all the time in your hand and suture should be tight enough. असं लिफ्ट कर म्हणजे मला दिसेल. कॅमेराला दिसतं का बाबा? का माझं डोकं आहे?
नाही नाही दिसतंय सर.
गुड गुड. चला म्हणजे बघितलेत कोणीतरी.
हां ती बघ.
As usual, this thread may be little, shorter, but still we can manage. I will show you how other knot can be put. And whatever at 9 o'clock, 12 o'clock you create tents, so you will not go deeper. In male, you can go through prosthetic capsule. In female, you can go through vagina. So we can avoid that. Visible आहे का सगळं?
हो सर, व्हेरी क्लिअर.
So what is important in total operation is creating tent for everything. If you don't create tent, you will go deeper, you will miss everything. See, and every rotation you should see base of your stitch. If that is going inside, again you have to re-rotate it and bring it back. Now what is happening? That stitch is becoming smaller. So I have to relax, before I hold it. Are you seeing it?
Yes.
कणेकर?
हो सर.
नक्की?
हो हो नक्की नक्की.
नाहीतर काहीतरी सांग, तू काय मला प्लीज करायचं म्हणून सांगशील हो म्हणून. Yeah, we have come there. Huh? See, now we have come to the nearly 9. हे आत घाल.
Complete host 3
o'clock. Okay. We have finished. So we started at 3 o'clock. We have come at 3 o'clock. We have joined that old stitch. Now I'll show you. Now thread is very small. I cannot put it as a loop, as a knot. And now what I can do? एक तुझ्याकडे एक आर्टरी तुझ्याकडची. नाही नाही तीच घे. तू मला काय पाहिजे सांगतो तुला. हा धर घ्या. निडल धर फक्त. See, I have taken as usual 2 locking stitch.
Okay.
And 2 stitches I am going around the both threads. Is it clear? Are you seeing?
Okay. Yes.
Now this is second round. Now this stitch or needle I will go through loop again. Yeah, loop there. Needle there ना. But ठीक है. Now see, I am now doing nothing but all knot is there. That is called reef knot. Okay.
Okay.
Still this much thread is there. So scissor दे. कशाला पाहिजे बांधायला? असेल ना त्याला कशाला मी ओढत बसू. Give another stitch.
Last step you understood that if it is too small, you are not able to
असेल तर
tie
चांगली
to
गोष्ट.
the other
मला हे
thread that which is left
old
long.
हे
That's why this
dog
reef knot is taken.
नाही दुसरं दे ना चांगल्यापैकी. ते तयार करतो तोपर्यंत.
And that will lock also equally firmly.
Okay, are you happy for first line?
Yes sir.
आता हे वर घे. द्या. सेकंड द्या ना स्विचर. काय?
नाही हे मोठं देऊ का?
नाही नाही वाय मोठं
नाही नाही जाड निडल आहे थोडी, तेच देऊ दे.
30 mm 20 acryl. हाँ 90 सेंटीमीटर सोड रे 2 mm दे.
थोडं कमी होतं ना.
तिच्याकडे आता काय करणार आहे
लहान होतं म्हणून झालं.
बघूया
सर नाही कमी होता.
तू करतोयस
नाही नाही सर.
ठीक नाही जस्ट विचारलं तुला. दिलीप हो गया क्या?
नेक्स्ट टाइम
अरे चल चल ठीक है 1-2 मिनिट. दे ना माझ्याकडे लगाओ. Same thing again. We are going to put line above it. हे वळवू नको.
next line is another 2 centimeter.
2 centimeter above it. Are you seeing this line?
Yes.
Can you see it or not?
Yes, we can see.
Now we'll tie this there. मला थोडंसं लाईट देतो का रे इकडे? येतं टोक धर. See, we have to adjust this thread again. एवढा मोठा बांधला ना तर तिथे काही राहणारच नाही थ्रेड. ओके सी दिस मच आय यूज्ड. दर आणि वेळ घालायची गरज सोड. हे फक्त यू पुश इनसाइड. ओके चालेल का? नाही सोडून दे. पाहिजे तर यू कॅन यूज दिस थ्रेड ऑल्सो आफ्टर टाइंग. if it is remaining long come in the way you can remove it also. Now can you switch off this light?
Sir, now you have taken first row at 2 centimeter above dentate line.
Correct. This
and
is
then now you are taking 4 centimeter above dentate.
above dentate line.
If you reverse this, is there any benefit?
Nothing.
Nothing. Okay. Okay, so you can take any row which you want to take.
काय झालं
Sir,
याला?
any advantage, sir? Upper row we can take first because if any oozing is there, that will trickle down because of.
नाही nothing will happen. Now also whatever row is there it will trickle inside only. It will not come outside because that proctoscope is of that type of, you know.
Sir, when we are operating, our thread never passes in. We in fact save almost 15 centimeters of the thread. So what can be our policy?
If same thread you have used,
90 centimeters.
I don't know. See, two things are there. My stitches are less than 1 centimeter always.
Okay.
If this needle can take 2 centimeter stitch also, and that will cut through later on, not now.
Okay.
And there you require less because your double locking is less than. See, can you see this? I am going 2 centimeter, and this becomes easy. Remember. Can you see? Kanekar.
हाँ बोला sir.
See, I create tent.
Yes.
That's why even second stitch becomes easy for me because it comes in my field. Okay?
Correct. Yes.
See. Can you
Yes.
recognize this?
Yes. Yes.
Usually people think the 4 centimeter higher stitch is difficult to take. Okay? But that is not so because that mucosa is laxer than earlier. Okay?
Okay.
That's why it comes in our view very well. Okay?
Yes, sir.
See, when I make a tent, my stitch is not very long. I go through that tent only. I don't go par and par. That's why they are very small and stitch used for this one. Are you seeing inside?
Yes, sir.
Kanekar?
हो पाहतोय.
नाही नाही मला खात्री करायची आहे तुम्ही बघताय म्हणून.
हो दिसतंय.
अरे सगळे जेवले तर झोपला असेल तर मी कशाला करू एकटा?
क्लिअर
मी पण झोपतो रे.
क्लिअर दिसतंय.
दिसतंय ना क्लिअर?
हाँ एव्हरीबडी.
मग सारखं सांगत राहा रे. मला काय वाटतं ठोक आहे काय सगळे झोपतात आनंदानं आणि मी आपला एकटाच करतो इथे. नाही वरती गेल्यावर त्या मिकोजाचं सुरकुत्या झाल्या बघितलंस का त्या?
येस.
हा. सो यू always you keep your eye on how rectal mucosa looks. Okay?
हो.
असं आता माझ्याकडे दाखव, कारण काय झालंय ते कॅमेऱ्यासाठी मी इथे बसलो ना. झालं काय कर नाही, थोडं बदललं ते. ठीक आहे, हे दिसतं का बघा.
नाही, आता तुमचं डोकं मध्ये येतंय सर.
मी नुसतंच बघत नाही, मी खात्री करून घेतोय तुम्ही जागे आहात, बाकी काही नाही. ओके.
हो.
आता अनफॉर्च्युनेटली उजिंग झालं नाहीये कुठे, झालं तर त्यालाही स्टिच तुम्ही घालता ना.
कशी घेतात ते
सी आय कॅन शो यू लास्ट स्टिच हाऊ वी शुड टेक इट.
ओके.
हे डबल लॉकिंग आहे. ओके. आता हे बाहेरच्या बाहेरनं आत आणायचं आणि इकडे करायचं, म्हणजे दिस बिकम्स ट्रिपल लॉकिंग. ओके. म्हणजे ब्लिडिंग होतो ना त्याला एकदम टाईट नॉट बसते. हे बघा आता समजलं का.
हो हो.
काय काय समजलं सांग मला एकदा.
सर
अरे काय नाही, स्लीप सिंड्रोम मध्ये येतो.
नाही पण आता
करेक्ट करेक्ट. हा बघितलाय माझ्याकडे लॅप्रोस्कोपी वाला. हा काय म्हणाला.
नाही, कॉम्प्लिकेशन करूनच दाखवा,
No, it
ब्लिडिंग
just comes to
करूनच
you.
दाखवा एकदा.
तू पतंग उडाला पाठीमागे मांजा कापायचा नाही कोणाचा, आपल्याला इथंच फक्त बघायचं आहे. नेडलं गेलेली कुठं तरी.
We should see any knot tightening, we should see the dimple there. Knot अंदर जाता है ना, tight करेगा.
थोड़ा लिफ्ट करायचा. हाँ, तो उनको भी देखेगा, मेरे को भी देखेगा. ओके. सी हाउ इट रिलेट्स.
येस, करेक्ट.
करेकर.
हो, दिसतंय सर.
नाही दिसतं का. दिसलं नाही तर वाईट वाटेल रे मला.
नाही, सगळ्यांना एक्सप्लेन केलं मी.
आता वरती अशा गाठी का दिसतात ठोक आहे काय. रेक्टल म्युकोजा फार लॅक्स आहे तिथे.
ओके.
हा, मग त्यामुळं म्हणून मला ओढलं ना तर तो लॅक्सिटीचा काही प्रश्न येत नाही. बघ मी लूज सोडलं तर निडल गमावली माझी इथे.
बरोबर.
म्हणजे मग मला पुन्हा एकाने ही निडल काढायला लागते. हे बघ. ठीक आहे.
हो हो.
सो वॉट एव्हर हँड इज देअर ऑन अदर थ्रेड ऑफ द निडल. सी हा आहे ना, हा थ्रेड कधी लूज सोडायचा नाही.
बरोबर.
मग यातनं निडल घेतलेली आहे ना, जोपर्यंत या निडल ओढणे पकडत नाही तोपर्यंत सोडायचं नाही. ओके. आता बघ लगेच हातात येतो. आणि हे फिंगर आहे ना, दिसतं का तुम्हाला.
हो.
का लाईट लावू दे.
नाही आहे सर, दिसतायत हातात. हा बरोबर, व्हेरी गुड.
दिसतं ना.
हा बरोबर.
हा बस या हे हात हे या फिंगर मधनं सोडायचा नाही. मग तुम्हाला कुठे गुंता होत नाही, कोणाला प्रॉब्लेम येत नाही, काही होत नाही. सी वी आर गोइंग इन, बट इट इज इजियर दॅन व्हॉट यू आर डुईंग अर्लियर. ओके. सी आणि तुमच्या हे लक्षात येईल वाय रिक्वायर मोर थ्रेड, यू नो, बिकॉज ऑफ दिस. क्लीन करू दे. फिरव थोडंसं खाली फिरव. त्याला सगळेच काळं झाले रे. गुड, थँक्यू. हां, वॉबल किंवा आडवी पडली की, आडवी पडली की सब म्युकोजामध्येच आहे. बघ कशी उभरते बघ. नाही बघ तू. सी. अच्छा सॉरी, मला वाटलं तुला दाखव म्हणून. कनेकर नाही बघितलं ना.
नाही सर, टीप दाखवा त्याचं, म्हणजे मग
कनेकर.
हो सर, तुम्ही
निडल उभी राहिलेली बघितलंस ना.
नाही नाही, टीप नाही दिसला ह्यावेळेस. दाखवा.
अच्छा मी दाखवतो तुला. युजली मला 12 o'clockला दाखवायची इच्छा नसते, पण तरीही दाखवतो तुला.
ओके.
थोडंसं इलेवेट. हे बघ असं कर, म्हणजे मला दिसतं. कारण मी या बाजूला आहे ना. हां जी.
Sir, do you ever use Deflon or Disoflav or any kind of flavonoids?
For what?
Before or after the surgery? Some people use if they find bigger hemorrhoid, they say ki you should use it for 7 days or so.
They can keep on using same thing, need not to operate only.
Okay, so you don't like them?
Why to use?
Vascular, some people use it. That's what I'm asking your this
No,
thing.
I don't use at least.
And what is your this thing antibiotic protocol after the surgery?
Any broad, हे जरा पाठीमागे ना. Any broad spectrum antibiotic plus metronidazole will be must होता है combination. Are you seeing now?
Yes.
हे बघ इथे उभी आहे. म्युकोजा मध्ये निडल उभी राहिलेली बघितलास ना.
नाही सर, त्या
अरे काय
आल्यानंतर दाखवा तो ज्यांनी स्कोपनी तो 12 o'clock ची पोझिशन नीट दाखवू शकत नाहीये.
बर ठीक आहे, आता बघ
जरा पुढे आल्यानंतर
आता दिसतं का बघ 12 o'clock?
येस.
हे दिसतं का?
हो, आता दिसतंय.
हा बस. हे बघ आता मी त्या निडलच्या इथून घेतो. ओके, उभी राहिली का निडल? हे बघ
नाही टीप दिसत सर.
नाही
नाही दिसत आहेत. हा
हा. अच्छा यांनी दाख त्याला नाही म्हणतोय तो.
जरा अबाउट 2 o'clock वगैरे आलात ना की ते दाखवणं जास्ती सोपं जाईल.
हे बघ आता 12 पासून 1 ला जातोय आपण.
हो हो,
वाजले की 12 आता.
हो वाजले की 12. येस.
हे बघ आलं का निडल?
हा.
आणि उभी राहिली ती. ओके, झोपली की मिळत नाही आपल्याला.
ओके,
ती काढून पुन्हा घालायला लागते, म्हणजे ब्लिडिंग सुरू होतं मग तिथे. ठीक आहे,
राहिली पाहिजे.
हा
झोपली म्हणजे
आता जवळपास 1 o'clock ला आले की आपण इथे जवळपासच आलो इथे इधर. बस
पकडता येते.
सी मी इथे फार डीप जात नाही युजली, पण नाही हे याच्यात सापडले. हां, कॅन यू सी इट? माझी बस बस ठीक आहे, चांगला आहे. थोडं गेलं. हां.
After your this procedure, the sale of the stapler has come down very significantly. All my friends who are in the stapler business, they are cursing me.
मेरे को मेरा एक क्वेश्चन है तुमको. हाउ मच डॉलर्स वी सेंड बिकॉज ऑफ स्टेपलर्स टू अब्रॉड? बोलो.
Yes.
कितना है बोलो. हाँ, यस नहीं है, कितना है?
That is a question, not a comment. Okay, I don't know, sir.
क्या है?
I'm already worried about my friends in the stapler business.
मैं भी उनके लिए वरीड हूँ, बट आई वरीड मोर अबाउट माय कंट्री मॅन देम. टोटल यु नो. सी ते आत गेली, मी लूज सोडल्याबरोबर आत गेली निडल, मला पुन्हा घालायला लागणार. ओके, कनेकर.
येस सर.
इकडे हेमंत आहे ना, हा इतका काही चांगला मदत करतो, त्यामुळं मला काही प्रॉब्लेम नाही आहे बघ.
बरोबर.
हे कुठे गेलं रे? हां हो, मी जरा हात धर हे करतो.
नाही सर, इकडे थ्रेड अडकली.
थ्रेड कमी
ह्याला
झाला. हे तू इथे
लाईट सोर्सला अडकली आहे थ्रेड.
See, we must say that we are lucky to have a senior most surgeon from Thane, Dr. Chivte sir, in the Godrej Hospital OT. So basically, Godrej Hospital is lucky to have them. And so is senior consultant from Fortis Hospital, Dr. Hemant Patil has also joined us.
Now we'll tie it here. 1 o'clock we have come. इधर लाईट लॉक आर्टरी रे, कारण फारच शॉर्ट झाले तो, कारण शेवटच्याला मिकोचं खूप होतो ना. का Are you seeing?
Yes.
We are double locking as usual. Now I'll rotate thread around it.
Okay.
Are you seeing? Kanekar?
Yes sir. Yes sir.
दिसतं ना?
हो हो, दिसतंय.
हा, हे बघ.
करेक्ट.
ठीक आहे. आता हा ही निडल आहे.
ती पुन्हा आतमधून गेली.
पुन्हा सेम व्ही मधनं आलं इकडे, बरोबर.
करेक्ट.
हा, आता घे, पुल कर ना. अरे मैं किधर से सब नॉट लाऊंगा यार, ओरिजिनल मेरा कुछ नहीं है इसमें. हो गया क्या, लाव.
एक्सिलेंट सर.
हा, असेल कुठेतरी, बघतो ना मी. काही ॲडव्हान्टेज नाही.
तिकडे नॉट मारलेली ना, पण एक आपण थोडा ठेवला होता ना.
ओके, क्लीन, नहीं नहीं, क्लीन करके दिखा देंगे. अभी लाइट लाओ, क्लीन करो, जरा हाथ टाका. आर यू सीइंग इनसाइड नाउ? कनेकर, कनेकर.
येस सर.
दोन्ही लाईन दिसतात का?
दिसत आहेत.
बघ.
येस.
ठीक आहे, आता मी फिरवतो जरा हे धर ना वर. आर यू सीइंग बोथ लाइन?
थोड़ा ये कर दो, जूम कर दो, जूम इन.
हाँ, कट करो, चलो. इसको बहुत बुरा लगता है, कट करो. नो, इट इज फॉर पट, आणि उसको दे दो.
सर 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 वहीं पे रखना है. ही जूमिंग इन टू शो द लाइंस. थोड़ा सा जूम और अंदर करके दिखा दो.
ओके.
या
नहीं, ये लाइट कम करो, अंदर का दिखेगा. और तुम्हारा क्या हो गया दाई का? ICG क्या हो गया?
ICG डाई अब ऑलरेडी दे दिया, जस्ट यू टू शो नाउ.
डालो ना, मैं इधर पकड़ लेता हूँ.
ये मोड बनाओ.
हाँ सुयश.
कनेकर.
Yes, sir.
We'll show you how much ICG will come through this lines.
और ये तू this thing हेमंत, हेमंत स्कोप से डालेगा तो लाइन अच्छे से दिखेगा. 30 डिग्री एंगल है ना.
देख, मला थोडं क्लीन करा, मी क्लीन करून घेतो.
ठीक है.
यस यस.
फोकस हो रहा है.
हाँ थोड़ा सा.
सर जरा ते ब्लड वाईप करून घ्या.
हा, घेतला.
गुड.
अरे वैसे हाँ.
गरम पाणी दे ना. थोडं बाहेर. उलटा नाही, असंच करायला ना ते. थोडं बिटाडी दे मुझे गरम पाणी दे. बारीक
हे मी धरतो, तुला मदत कर, त्याला सोड. अरे आरटी बघ, आरटी क्लॅम दे ना बाबा, साधा हातात आहे तो दे ना, काय कशाला हुडकत बसते.
ICG मोड करना पड़ेगा ना, IR मोड. फॉग होता है उधर जाने के बाद. ये क्या ना, IR मोड नहीं होगा तेरा अभी तक.
ये भी मोड डालना पड़ेगा ना.
इथे बॅटरी ठेव ना बॉल मध्ये.
मी थोडं मागेच ठेवतो.
हा, बस बस. हा,
कम कर दे.
लाइट कम कर दो.
कम कर. और एक मोड रहता है, दूसरा मोड को AMD मोड है ना. हाँ.
सर ते म्युकोजावरचं ब्लड पुसून घ्या.
चालेल चालेल. तर एक मिनिट करून.
पूरा येलो ऐसा नहीं दिखना. वाइट बैलेंस को
कुछ आगे लग भी गया.
मोड की वैसे ही नॉर्मल मोड करो. ये नॉर्मल मोड जो है ना, वाइट बैलेंस ऑलरेडी है. नहीं, ये नॉर्मल मोड है. हाँ. अभी जरा ICG मोड डालो.
बस इथेच ठेवू दे.
नहीं, अंदर ये कुछ दिख नहीं रहा ना, वो फुल ज़्यादा वो. सर ते स्कोपचं वरचं लाईट बंद करू का? हो करा. अभी करो ICG मोड. नहीं, बहुत ज़्यादा हो रहा है. ठीक है, वो नहीं होगा. और कोई मोड ऐड करें इसमें? AMD मोड. नहीं, इसमें कैसा होता है ना, पूरा ऐसा वेसल दिखेगा, दो जगह पे आपका आर्टरीज बंद दिखेगा, इधर आईसीजी दिखेगा, इधर आईसीजी दिखेगा, जो स्टिचेस है ना उतना सेगमेंट में आईसीजी नहीं दिखेगा।
लेकिन इसमें कुछ प्रॉब्लम दिखा है ना सर?
नहीं, उसको मालूम नहीं रहेगा, वो उसको बुलाते थे हो जाता। तो फैंटास्टिक सर, वेरी गुड।
अच्छा निकाल, लाईट लगाव अभी.
लाईट लगाओ.
हां काढा आता. आता काढा की बस. यांनी काढला आपल्याला ठोकू नये काही.
फर्स्ट क्लास.
आता पूर्वीचं पिक्चर आहे का याच्यावर हे द्या ना सलाईन.
ओके. वो आएगी.
काय मग आता बघितलं
उजिंग आहे सर.
मग काय अरे यांनी चांगलं दिसतं ना, ते अर्ध दिसणार फक्त तुला. तेच रे तेच तर करता. चल ठीक आहे. एनिथिंग टू बी डन. चल
I got privilege to work with sir.
हां
सरांना म्हणत होतो मला
हां टाक काय कर, काही केलं नाही तरी चालेल.
बाहेरून फक्त
माईक तिकडे जायचं आपल्याला. माईक असू दे. बस काढून काढ काढ.
हॅलो.
6 o'clock, 6 o'clock abscess है ना.
हाँ पूरा क्लियर है. हेलो. Can actually feel fluctuation. 2 o'clock to 10 o'clock I mentioned in this thing.
Hello. Hello. Hello.
हॅलो.
Kanika sir.
हॅलो.
Kanika sir, can you hear me?
हॅलो.
Just a minute.
Yeah, there is a
Yes.
extended.
Hello.
हॅलो.
This is the skin outside. Superior extension it is here. It's till this level.
क्या बाजूला?
Hello. Kanika sir.
हां नाही
Till this level.
आवाज क्लिअर नाहीये.
हाँ Kanika sir, अभी now nothing here. Hello.
दिख रहा है ना.
ये prostate है.
Dr. Kanikar.
हां आवाज येत नाही.
Abscess.
ऐसा है ना.
आवाज नहीं आ रहा.
The sound is not very clear here.
वॉश किया ना तू?
हाँ.
नाही आहे. ते काढणं तर तो स्कोप घेतलास ना?
हाँ हाँ. तो स्कोप है ना.
आपल्याला हे पण लागेल
सर ये horseshoe shaped है ना. inferior extension नीचे से है ना.
From 2 o'clock to 10 o'clock they mentioned.
हाँ ऐसे जा रहा है ना. हाँ.
हॅलो. हॅलो.
Hello.
We need to know about the case.
Rahul, Dr. Rahul here again. So this again we are performing a transrectal ultrasound in a patient with perineal abscess, and this is the again the rectum and the anal canal. At the low anal canal, posterior to the low anal canal, we can see this small pocket of fluid collection in this area, in the subcutaneous and the perianal fat, and this is in the shape of a horseshoe shaped abscess, extending right from 2 to 10 o'clock position. Suspicious internal opening is seen at 7 o'clock position, 7 to 8 o'clock position, on the right side, or here, this one, and here is the internal opening at this side. We can see the
Anyone who is well versed with sonography here in the audience,
and the abscess
so he can
at this level.
talk with him.
We can see the mobile internal echoes in the
Yes,
abscess.
those
If you
we can see.
If you can
Yes, that
concentrate,
is a abscess.
there is this
Correct.
fluid movement, if you
Yes,
can appreciate.
Correct, yes.
So
Now,
this
show the internal opening, how to identify internal opening.
I'm sorry. So basically, we have to trace the abscess and see the defect with in the mucosa.
Huh.
And over here we can make out.
Where is the mucosa?
Mucosa and the wall. So, okay, again to the basics of ultrasound of the rectum. This is the anal canal, and here we have this mucosa, submucosa layer, and the muscularis layer and the muscle, and internal sphincter. And in this case, I just come to the abscess again. We have to move out little bit because it's quite superficial. The collection is getting is in communication with the rectum at this juncture. We have to. It's a very minor defect. You can make out. So here we have the fat plane between the abscess and the anal canal, but in this small focus, it's absent.
Okay.
Again, the fat plane exists. So this is the internal opening, and we can actually also see these small white dots, which are nothing but the mobile internal echoes of air pockets, which are moving in and out. Yeah, thank you. Yeah, sir. Thank you, sir.
नहीं सरळ दे सर डॉक्टर जी
मला ग्लोव्स तेवढे द्या ना
सर इस केस के बारे में डॉक्टर राजपाल बताएंगे कुछ डॉक्टर राजपाल दिस पेशेंट इज
एज कितनी है सिस्टर एज कितना हेलो हेलो
Hello. Yes.
Yeah. Kanika sir, this patient is a 41-year-old male patient. He is having perianal abscess. He presents with severe pain in the motion area, fever. WBC is 13,000. So outside clinically we cannot see anything. So this
bright glow there.
So we got MRI done. MRI is showing horseshoe abscess from 2 o'clock to 10 o'clock position, and there is a suspicious inner opening also, which is opening at 8 o'clock position.
Okay.
So the plan is to do IND curettage, and then endoscopic we'll just view what is happening and close the internal opening.
Okay.
You can see the pus which is already flowing out.
That is too much of brightness there. The light is too bright.
तुम्हाला हे ठेवायचं तुमच्यावरती हां बस हे तुमच्या वरती ठेवायचे नाही अगदी सर काय पाहिजे
स्टूल इकडे ठेव या बाजूला एका बाजूला
इकडे हां काढा ना
कॅमेरा वाल्याला पण
माईक लो
जेली दे मला जर कनेकर
हां बोल सर
हां हे बघ
clinically also, this fellow has got swelling up to here.
Correct.
हे बघ.
Okay, yes.
ते अल्ट्रासोनोग्राफी दाखवली त्यांनी,
Yes.
पण फ्लक्च्युएशन इथंपर्यंत आहे हे बघ.
Okay.
आणि मग मला इथे रेक्टल वॉल प्लस इडिमेटस पाइल्स एव्हरीथिंग आय फील हिअर. ठीक आहे. पोस्टिरियरली इथे मला काही लागत नाही, पण हा बघ इथे दाबल्याबरोबर यू कॅन सी दी पस. कॅन यू सी?
येस.
हां. तर त्यानंतर या इकडची वॉल पण फील्ड आहे ही बघ. हे बघ फील्ड आहे माझ्यावरती. पस यू आर सीइंग. ओके.
ओके.
मला सिम स्पेक्युलम दे. लेट्स सी दॅट. मी बघितलं नाही ना अजून. हा हर्षू हे मग हर्षूच आहे ना हे. कॅन यू सी दिस? हॅलो.
येस सर.
हां मी काढणार नाही सगळा पस. का ठोक आहे का?
हां.
आम्हाला इन्सिजन ड्रेनला जागा पाहिजे इथे.
करेक्ट.
कॉटे आहे तुझ्याकडे? See, I can approach from here up, down, okay, and side also. So I'll take first incision here.
This is
Alice. नहीं कुछ ये तो पस तो ड्रेन करना पड़ेगा ना आपको. देख usually you can test with, some needle or anything. 18 number needle, if you test, you will know abscess where, and abscess is there. Here now already you are open, and articulum. Okay? Let's see any pus comes or not. Or it is subcutaneous region only. एक मिनट. पैड दे मला क्लीन करायला दे. See, we have opened subcutaneous plane as well as we have reached up to fossa. Pus is not coming. That means this is intrasphincteric space is involved in that. Okay, here is, I am going up to bone, but there is no pus discharge. But inside still bulge is there, this bulge. Submucosal bulge is there. Now what we should do it? This side also I will just see it. Here it is not much bulge, but आता बघूया ना काय करायचं ते. See, if it is only intrasphincteric, you can drain from inside. There is no problem. Okay, दे. Speculum दे. काय चालेल ठीक आहे. Okay, hold it. It is already open here, submucosally. Okay, can you see? I don't want to open this and connect this space here. Okay, can you imagine what happened? Now this side we can see whether anything. There is nothing much pus here, so there. Here you can see all this. It is interesting trick. ते MRI वरती काय दिलं बघणार आहे? ओके, सी बोट घाल ना इथे, म्हणजे इथे आपण ओपन केले येत नाही आहे पण इथेपर्यंत येतं ते. हां, तर ड्रेन तर झालंच ना.
कनेक्ट होतं ना पण जाते आय कॅन रीच हिअर. सर आपण 6 o'clock पोझिशनमध्ये जाऊन तिथून
बघूया ना आता. हे बघ, हे इथे ऐकून घे. हे बघ, माझा फिंगर इथेपर्यंत जातो, समजलं का? म्हणजे सेम कॅव्हिटी इज देअर. सो दॅट कॅव्हिटी ऑल्सो वी हॅव ड्रेन्ड. व्हॉट विल डू, विल मेक वन मोर होल, सो विल ड्रेन दिस ऑल्सो. ओके, चलो. नाही नाही, मला अरे कॉटरी दे ना राजा, इथे क्लीन कर जरा. दे इलेक्शन धर. दे आर्टिकल दे. सी माय फिंगर इज हिअर. हॅलो कणेकर.
येस सर.
आहेस ना बाबा?
हो हो आहे आहे.
नाही म्हणजे मला जरा भीती वाटते एकट्याने करायला रे. हे बघ,
येस,
ही कॅव्हिटी आहे, मगाशी मला मिळाली नव्हती पण वी कॅन सी दिस. आणि ही इथे माझा फोर्सेप्स इथं जातो, समजलं का? आणि याच्यामध्ये आत बिग एडिमॅटस घाल, बोट घाल. जातं का बघ तुझं, नाही तर मोठं. हां, त्यात नाही
आहे ना
कम्युनिकेशन. येस, कॅन यू सी कनेकर?
येस सर.
ठीक आहे, चला क्युरेट द्या. हे बघ, क्युरेट रे, हे स्कूप आहे. हां, करेक्ट, व्हेरी गुड, शार्प नाही. हा, मला वाटतं स्कोप अगोदर घालून दाखवू दे, पस कसा असतो ते. या स्कोप द्या, का दाखवतो. नाव we'll do scopy for this and then we'll see what we can do. IV बॉटल, नीडल. हे जरा माझं पाठीमागचं स्टूल काढून घे, मला उभारून करायला लागेल आता. स्टूल काढ जरा. हां बस, हे जवळ घ्या. लाव त्याला, लाव, फोकस कर. आणि हे दे लाईट सोर्स. वाईट 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 वाईट. लाव. ओके, वॉटर कनेक्शन. मला हे दे वाइट. राजपाल, इसका वाइट वगैरह करो, सब कुछ फोकसिंग करो. saline, saline. हाँ, अरे तुम सिंपल तो दे दो मेरे को, आईवी सेट लगा के दे दो, स्टाइल घ्या आईवी सेट तुझ्याकडे. हो गया, अच्छा फर्स्ट क्लास. चल दा आईवी कनेक्ट करता, जवळ घे, जवळ घे. हां, मग इतक्या दूर कसं येणार रे. कनेक्ट कर त्याला, एअर काढा. हे लाव, इकडे लाव. गुड. ठीक आहे, वाढू नको. Can you see the cavity now? Hello, connect कर.
थोडंसं ब्लड आहे सर.
ब्लड तर आहे, अजून क्लीन व्हायचं ना ते. आता सलाईन घातलं ना.
आणि जरा फोकसिंग लागणार आहे.
हे बघ आहे रे, हे बघ, हे होल दिसतं का ते.
यू कॅन सी नाव.
जरा हे लाईट थोडं मला कमी कर.
लाईट ऑफ करा.
This white and yellow pus. This you are seeing all pus pockets.
Yes.
You agree with me? Already sonography person has showed. Then we could go through the finger examination. Now, see, all small pockets are there. Means this is abscess from a long time. प्रेशर वाढव आता जरा, रिव्हर्स मध्ये. See, my finger is here. You are not seeing very well because water is draining in the, because big hole we have made it inside. Okay? So, दिसत नाही ना. हे बघ की वर होल आहे. हे मसल फायबर दिसतात रेडी. नाही, इथून आपण होल नाही पाडले याला खाली आत. हा आत आहे ते, पण हां हां ते नाही, इकडून एकदा पुन्हा. अरे वॉटर जरा थोडं प्रेशर दे, प्रेशर दे, प्रेशर दे, प्रेशर दे, साफ होऊ दे एकदा. See all pus, and here is opening, that one. See, this is the hole in the perineum, not perineum, dentate line. Okay? Are you seeing inside now?
हो सर क्लिअर नाहीये पण पिक्चर ते
जरा
कदाचित त्या
राजपाल
पसमुळे
focusing
तसं
करा.
असेल पस ब्लड मुळे
एक मिनिट.
I will change.
This is rectal mucosa what you are seeing inside. Here rent is there. From where pus has drained. Okay? We'll curate this and then we'll show you again.
इंटरनल ओपनिंग कुठे आहे सर?
आता होता मी जरा एक क्युरेट करतो त्याला.
ओके.
क्युरेटिंग ते मला एक ठेवून दे. हे घे. पाणी घेणार राजा. राजपाल उंगली डालो अंदर, ये क्यूरेट करो. ये रेक्टल वॉल के ऊपर ही है. और सीधा सीधा जाएगा नीचे. हाँ उंगली डाल के करो. सो विल नॉट परफोरेट देयर आल्सो. हळू हळू प्यार से करो, प्यार से करो. अरे इकडे काहीतरी टाकून द्या ना बाबा, पडून जाईल ते तर आम्ही. टाक इथे. ठीक है. एक 5 मिनट हो जाएगा. वरतीपर्यंत गेला बघितलं ना. हां म्हणजे हां तेच ना. म्हणजे वी हॅव ओपन इन राईट स्पेस. फक्त त्या आतल्या बाजूला होल असल्यामुळं थोडं ते काढ. ते बायोप्सीला पाठव ना. हां काय घेत बस. हे टिश्यू पण घे ना. आता बघू या बाजूला किती काय खाली आहे बघ. रेक्टल मिकोसिस तिथे. हे ॲप्रिस वरपर्यंत गेला ना इकडे.
आपण जर आता असं डेंट केलं तर
नक्कीच होणार, कारण इथे फार मोठी गॅप आहे. आता इडिमा असल्यामुळे वी कॅनॉट क्लोज इट, यु नो. हां काय नाही नाही, फॉलिश कॅथेटर यात घालायचं ॲप्सेस ड्रेन व्हायला, त्याच्यानंतर बघू काय राहतं ते. थांब सर, हे करायचं नाही, संपलं नाही अजून. हां चल आपण जर पुन्हा एकदा बघूया स्कोपी करून किती राहिलं आहे ना अजून.
मेजर कट वाचलं ना त्याच्यात.
प्रेशर दे, प्रेशर द्यायला. See, this is upper part of fistula.
After curative.
After curative. See, now fibrotic things are seen. This is going to the levator ani. ये देखो एलिवेटर है ना इधर, ये दिखता है क्या? ये करा, हाँ क्लीन करायला लागेल. हे काही तर राहिलेलं आहे ना, जरा दे.
मोठा पण घेतलाय ना, मोठा बराला लिहा था.
नाही हे नाही, याला काही उपयोग नाही. ते रिट्रॅक्टर आहे, क्युरेट नाही आहे तो. हे चल ऑन कर म्हणून त्याला.
प्रेशर दो.
हे माझं हे लाईट इथला जरा कमी केला तर मला दिसेल जरा बरं.
ऊपर का लाइट ऑफ कर.
लाइट बाजूला घ्या, बाजूला.
सर ये दिस थिंग फोरम का यूज़ करते हो ना?
हाँ
ये फोरम का स्कोप यूज़ करते हो ना सर?
क्या जी?
ये फोरम का है ना स्कोप, 4 मिलीमीटर का.
हाँ 4 mm का.
3 mm का भी आता है क्या सर?
नहीं आता.
ये यूरेट्रोस्कोप वगैरह.
वो तो अलग है, यूरेट्रोस्कोप्स आर डेलिकेट.
अच्छा अच्छा अच्छा, ओके. और फ्लेक्सिबल रहते हैं.
हाँ फ्लेक्सिबल रिजिड दोनों है. देखो ऊपर तक गया, देखे ना ये फिस्टुला. देख वी आर क्यूरेटेड हियर. वो येलोइश है, वो फैट दिख रहा है अपने को. ये देख ऊपर भी गया है, नहीं इधर तक ही है, उसके ऊपर नहीं है. देखे ब्लाइंड एडा गया. ये देख है, ये फिस्टुला का एज है, देखे है. और ये ऊपर दिखता है वो प्यूबोरेक्टालिस है. ये देख, ठीक है. ये देखिए, सी आई एम सो मच डीप. नहीं प्यूबोरेक्टालिस कंफर्म करने के लिए ये भी निकाल सकते 10 सेंटीमीटर. आई मीन एक काम करेंगे, इसको पॉलिश कैथेटर डाल देंगे, बस हो गया। और अंदर का क्या करने का बाद में सोचें, आफ्टर हीलिंग, बिकॉज यू कैन नॉट क्लोज बिफोर यू नो इट हैज बिकम मैच्योर्ड।
पॉलिश डालें, कोरिगेट ड्रेन डाल देना।
नहीं नहीं, पॉलिश 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 दे।
कौन सा नंबर?
14 नंबर है। 14 12 कोई भी नाही. हां ते काढून टाका ते. अच्छा बघ ना तो पाईल्स आहे रे. दॅट यू काय पाईल्समध्ये इडिमा आला की जाणार नाही ना ते. आता काही दिवसानं जाईल ते.
वरती फक्त पू एक्सटेंड होत नाही ना.
हे बघ ऑलरेडी झालेलं आहे, तेवढा काढला आपण. मला काहीतरी डायलेटर आहे का हे का काहीतरी असं हेगार्स डायलेटर वगैरे काही आहे का तुझ्याकडे?
टाकू कमी
टाकायला वर पर चल इन्फ्लेट कर ड्रेसिंग दे नुसतं मग. त्याला पुन्हा लागणार आहे. पुन्हा दिलीप पुन्हा लागणार आहे ट्रीटमेंट. चल ठीक, थँक्यू. हां काय असेल ते काढून टाक. हां काय
ट्रॉलीचं काढायचं आहे, काढू का? काय एक मिनिट काय काढायचं?
हेलो 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 the final comments on the case please. No, I can't hear you. We can't hear you.
Hello, Kanekar sir.
Yes.
Yeah, sir, we have finished over all the cases today, and I'll just take a minute of yours. I'll want to show all my staff who have taken out their time on Saturday and Sunday, and they have been working like anything.
Yes.
They have given their 100%. You have met Dr. Rachit Jain yesterday. He's the anesthetist with us. He's a handsome guy. Just Rachit. Thank you, Rachit.
Thank you, sir. Thank you so much.
He was the man behind the curtains because of which all the patients we could operate.
Sir, it was my pleasure to be here, sir.
Thank you. And Amol, Babban, Bharat, brother, sir, come here, come here. Nurses, Adira, Aruna.
Hello.
Aruna. Aruna. Hello. I want to officially thank them all.
Yes, good work from all of them. Thank you very much.
Officially want to thank them.
We want to appreciate them.
Yes. 3 claps for them. Yes. Good. Thank you so much.
Thank you.
Thank you, sir. Thank you.
Yes.
Now we conclude, sir. Thank you.
जितेन.
Yes, sir.
जर अच्छा तू
हाँ बोलो सर.
नाही आमचा भेटला पाहुणा. थँक यू व्हेरी मच.
थँक यू सो मच. थँक यू.
जितेन हॅलो. अच्छा जितेन पण येतोय.